Hello.
Hey Magnus, how are you doing?
Very well. How are you?
I'm good, thank you. So,
Good.
just wanted to check your setup, get you all prepared, and make sure that you're nice and comfortable before, because we're already live. So I just wanted to make sure that you were comfortable and ready for the day. It is in a while, but we are. This is a great opportunity now to just get ready and prepared.
Is that okay? The camera, my position here. Do you think that's perfect?
That's perfect. And are you set up with both screens again?
So we are thinking of using a different computer for when I'm going to see the presentation and the people who are speaking, because every time I shift presentation, we need to set it up again for some reason that I don't know why, but
okay.
But if I share now, I'm just going to see how this is going to look like.
Let's just see. Yeah, great.
Screen. But here I can actually, I want to share this one. Should I share system audio as well or not?
We need you to share system audio for when we do the last presentation.
It's only the award.
Only for the awards. For now, we don't need the audio, but I can mute it if need be. Yeah.
Perfect. So this is.
Codes, great, and it's in. Oh, perfect.
There you go. That is correct, isn't it?
That's great. That's exactly how it needs to be.
Yeah, because behind me, I have another screen where I see the next slide coming up. So that's okay.
Okay. Oh, that's great.
So that's great. The only thing I don't see now is myself and the one who is speaking.
Okay. If there are others, yeah. So for that, like you said, maybe what you need to do is just put that on a different PC, and then you're good to go.
I think that would be better, actually. That would be a safer.
It's more secure. It's a safer option, as you said. Yeah.
Definitely.
And then
and all videos. You're handling all the videos. I'm not doing anything on the video side.
I'm playing all the videos. So yeah. And then also we discussed instead of a 2-minute countdown, you wanted a 1-minute countdown. Are you still happy with that at the start?
Yeah. Personally, Camilla wanted one. To be honest, I don't care.
You don't care. Okay.
I don't care. I don't care about that. The only thing we discussed was that yesterday in the session, they showed how to get to the simultaneous translation part. Okay, because if you miss that when you look at the agenda, if you don't go up, because on the agenda it looks when you walk in, you have it on your left top. You have on your screen, you have a flag, and if you don't click on that, if you want simultaneous translation, you will not get any simultation. That is correct, isn't it?
So let me just, what I can do then, if you want, is when we start, if you want to do that from the beginning, I will share this in, bring that onto screen like that, and then we can show how you can get simultaneous translation.
Very good.
With the 4 different languages, and then enter. So you click which language you want, and then you enter the auditorium.
Yeah, and if you're in already the auditorium, which you will be if you listen to this, you need to go backstage. You have that on the bottom of the page. You need to go back.
Yes, exactly. So we can start if you like. What we do is we'll start in here. And you enter the auditorium. Where you'll say, I'll have that open there. And then we go back to lobby.
Bottom of the page, you need to go back.
Yes, exactly. Click back to lobby. Where then you'll do your selection of your
I don't know.
Of your language, and then enter.
Do you think we need to show it, or can I talk to it?
You can talk to it. If you want to show it, I thought maybe sometimes it's easier, but you can definitely talk to it. It would be quicker if you talk to it. And if you, because we've got a lot of content to get through as well.
That's what I'm afraid of. That we are.
Yeah.
I think I say that in the beginning on the main page, the front page, that the first page that we have. That's where I'm going to say it. So
perfect. Okay, great. And then, have we set up the other computer for when you talk with Max yet?
No, we haven't.
Okay, because I just want to make sure that we've got that camera angle correct as well.
I will ask Karin. Wait a second.
Okay, thank you.
Karin is setting it up now, so if we wait 30 seconds.
Okay, no, that's great. That's perfect. Okay, but I think you're comfortable. Everything's comfortable. We're just happy days.
Definitely.
So yeah. So from when
we just need to deliver. That's
exactly. So you'll see. You know how this overlay was on when you came in. That overlay will be on, and then 10 minutes before we go live, I will then switch from the overlay to the video. So it's the same thing, but it will just be video, and then we'll send out an audience message for them to refresh their screen if they're having an issue. And then from there, at 2 o'clock on the dot, that's when I'll play the countdown video. The countdown video followed directly by the welcome video, that intro video of Baxter. And then while that's happening, I'm going to put you and your presentation behind the video. So when the video ends, it goes straight on to you. Yeah.
Okay, perfect. I hope I can be there at least 5 minutes before, because I'm going to be in another session as well.
Yes. Look, if you are running late, there's not a problem. We have...
maybe Karin and Camilla can then just make so we start with the countdown a little bit later, if that's the case.
Just let me know, and then also I can put up a banner which will tell you what time. I can say that we will be, instead of starting at 1400, we'll be starting at 14:15 or what have you. Yeah.
Oh, it's not going to be that. It's going to be talking minutes, not more than that, because then we will ruin the whole program. I'm going to try to be fast there as well, but.
Okay. It's amazing how our lives have been controlled by digital meetings.
Yes, absolutely. Nowadays, that's how it is. But we save a lot of time and a lot of
money in terms of travel as well.
The environment, and also the environment.
I agree. Yeah.
Not bad.
Not bad.
Let me see with Karin.
Thank you.
She should be in there now, so you should see her.
I don't see her yet. Magnus, let me just check. Just make sure she's in the right stream. Here we go. She's here now, Magnus. Hi, Karen.
Hi.
Now you should see that.
Yeah, perfect. Thank you. Let's just put that.
I'm just going to get my stuff back from there. Yes, we check the setting here, so this is okay.
We did want it a little bit more of a tighter fit with this, but I think that's fine.
Is it a good position, or because this is how I'm going to sit?
Yeah. Is it possible to zoom in a little bit more, Karen, just to get closer to...
Closer?
Just a little bit. Yeah, that's better. Thank you.
Put yourself in the chair here, Karen, so we can see if we...
Yeah, I know, but like now they're gonna be like, oh, which tab? I know these people. I can't do it. So I'm just gonna delete.
Tuck. That's good.
Is it okay? Or
you know what, Karen, if you can just move the chair a bit closer towards Magnus.
Yes.
Yeah, just because it's that little bit there. Yeah. Okay.
Is this okay if we were sitting like this? Is that okay then if I now introduce Max Bell and what he's done and all of those things, and then we can start discussing. Okay, the first question is, COVID has put focus on many things in our society. And for you as an intensivist, what has that been? What's been the biggest challenge during the last year?
Yeah, I think that's good. I know Camilla did want it a little bit tighter, close, less of the legs and more of the faces. I don't know if that's possible.
You think we should?
Up a little bit.
Yes.
Yeah, just push it in a little bit. Yeah. There you go. That's great. Yeah, but now you've moved to, okay, back a little bit the other way.
Back a little bit again.
Yeah.
There you go.
Yeah. Perfect.
I think this should be good.
Yeah, that's great. Yeah. It's better.
Without the legs, it's much better.
Yes, and also if you can maybe just tilt the camera forward a little bit, because it's actually quite, there's a lot of gap between the top of your head and the top of the screen. So there's a lot of, yeah. Yeah, that's great.
Is that better?
Oh no! Now we still got the legs again, but in terms of yeah.
No.
Yeah. There you go. Okay, and that's yes.
So, Masha.
Yeah, that's better. Yeah, that's great. I mean, and we can see, and then Karen, if you can just say a couple of sentences so I can hear how you sound through it on the other side, because I can hear Magnus, no problem.
Hello, you are going to interview me?
Yes.
Okay, that's great. Thank you.
Is this okay? Because it seems to me that we are nearly disappearing out of the...
Maybe if you're a little bit closer.
Do you think this gap
Maybe it's also maybe the angle of the chairs. It doesn't have to be at such an extreme angle. Yeah, because we had it set perfectly. Now we're back into the. Yeah, we need it to be a little bit tighter.
Like that. Is that better?
Yeah. We had it set up perfectly on Friday. I'm just trying to think. Do you remember where it was when
That
you
was
left it?
much further away, though. The camera is much closer now.
Is it much closer?
I think it's nearly at least like 70, 80 centimeters closer to where we're sitting.
Okay. All right. And also, I mean, the sound is good, so we can hear you properly, and you're not too close for social distancing, which is good.
Yeah, but I think
If you need to worry about that.
use this one instead
But try the microphone as well. I think it's going to be better, isn't it? Or is it okay now?
Let me try with the microphone. That might work because there's a little echo, but
Hello. Sorry. You will be set. Yeah. That's communication.
Är den på? Is it on?
Can you hear us?
yes, I can hear you.
From the computer, though.
Yeah, from the computer.
Yeah.
Deep thinking method.
And say connecting. So
No rush. This is what we're using this time now for, is to just troubleshoot all these issues. So that's good. Yeah.
What happens if you put it into the USB port instead of
Maybe-
the Bluetooth?
maybe it's
Then
better.
that's always a safer card sometimes.
Just get you back ready to be ready to share whatever you yeah. Did you get my email?
Oh, I got the production schedule, but I haven't received the other ones.
Okay, cool. Just have a look and see.
now it's from
Now it should be okay, shouldn't it?
Yeah, it's great.
Oh, that's
Much
very-
better.
That's much. Is it better for you as well?
Yeah, it is.
So, gentlemen, letter.
You hear us better, Jackie, or
Yeah, yes, I can, Magnus.
very good, because I can hear you much better now.
Perfect.
Yeah.
Okay.
How about the picture? The setup.
The setup, if you can just sit back there, please, Karen. Just.
Can't come much closer because
And it does, yeah. It's a little bit lopsided, though.
Do you think we should shift the chairs?
I think Magnus is comfortable on that side. I don't know how tall Max is.
He is a bit taller than Karin.
Yeah. So, look, I think
it's okay, isn't it?
It's okay. It's not great because it is a little bit lopsided. Because I can see your legs are not Karin's legs, so I don't know if it's on an even
I think it's
surface.
the camera. It's not standing straight though. If you look at the legs of the camera, it's a little bit, that's why you get this.
Skruvar man upp den?
Nej, den är för huvudet, själva huvudet, den faller rakt ner. Jag tror att boxen inte är helt rak.
Ska vi hitta en annan box
Den
kanske?
står den också. Så man kan få den.
Bless you.
Thank you.
Okay, now the camera looks a little bit blurry. I don't know if you touched the camera with your thumb or something. If you can just wipe it, please. Sorry.
It's the light. It's gonna be better because the sun is just in 30 minutes. The sun is disappearing from here.
Yeah, no, that's better. Thank you, Karin. Okay, yeah, no, that's more even now. Definitely better.
It seems that it's more
Yeah.
both sides.
More,
If you sit there, Karin, then we can see.
yeah. You see, now you equaled. It's not uneven.
Yeah.
Yeah.
Okay. Well, that's better.
Okay. Yeah,
Now
much better.
It's much better in the picture at least. So
Yeah. Thank you. And now, Karin, you can't do any work because we're using your computer till the end of the session.
nice and comfortable, isn't it?
Yeah.
That's perfect.
My best for my
That's how it should be every day.
Great. Okay. So yeah, I think we're good. Magnus, and then yeah, nothing else that you want to test now? I think we're
I don't
fine.
think so because we know I'm going to walk between these two rooms twice. Then I think it's more what I said to Camilla. Questions for this session need to come in my team's inbox because otherwise I can't read the questions from here.
Sure, not a problem. She'll send them to you, and then if she sends them to me, then I'll put them on the comment section on the screen as well.
Otherwise, I will see it on my screen, my third screen I'm having, isn't it? So in the chat, isn't that where I'm going to see in the other questions? Like you said, yeah, last time it was question 1.
Yes. There will be those questions. Yeah.
And I click on the questions, or I just read the question there.
You just read the questions, and when you read them, then I'll click on them and post.
Okay.
Then they'll flat. Yeah. But you'll be able to see them if you're in the comments box.
Okay.
I'm not going to put any there now because it's nice and clean, and we want to keep it that until the start of the session.
Perfect.
All right.
Good. But I think we are good to go.
Yeah. Comfortable. Thank you.
Very good.
All righty. So we'll see you later. And Karin and Camilla will let me know what's happening in terms of time and when to start the countdown timer. And if you want that extra time, I can play the 2-minute countdown instead of the 1 minute. So that just gives you an extra buffer.
No, I'm fine. I'm fine with the 1 minute. It's absolutely okay.
Okay.
You know, maybe just send it to
Just in case.
But what I said to Jackie was that if I hope not delay from the first meeting, like we just need to hold it a little bit. That's what I get in. I'm going to see if this.
So much nicer.
Good, good.
No, okay.
So we have the ticker link, so you
Yeah.
know what? Okay.
Oh, your internet connection got a little bit unstable there. Was something happened there?
Was it?
Yeah,
Stable now, so it shouldn't be unstable at all, actually.
yeah.
Even more stable now.
It should.
And also, Karen, just please make sure when this is on that there's no notifications or Teams or anything like that open on your machine while we're running this session, please.
I will close everything down.
Yeah,
But
thank
I
you.
will do the same as well on my computer because it's also quite disturbing when things are popping into your screen.
Yeah, perfect. Thank you. Alrighty, and we'll see you in it's 1
It's
o'clock.
12 o'clock already.
Yeah.
So I need to figure out what I'm going to say in 1.5 hours in the other meeting. Maybe it's time to do that.
Okay. Alrighty. Good luck, guys, and we'll see you so
Okay.
shortly.
Thank you. Thank you.
Thank you.
Bye.
Bye. Tuck. Bye.
Hi, and welcome to an afternoon together with Acute Therapies. It is really an exciting time now, and you heard yesterday we focused on the integration of Baxter and Hillroom together and what we can do as one company instead of two different ones. Today, this is Acute Day. We're going to focus on celebrating 2021, another extraordinary year for this great team. Looking at the achievements, in the end of today, we're also going to hand out the EMEA Elite Awards to those who have been the best performer in the team. Today, we're also going to look a little bit ahead of time on 2022. What is our key focus in 2022? Christian Roberts is going to help us with that. And we have our Talk the Walk sessions in the later today, where we're going to focus on key things we're going to execute during 2022. And we have an excitement. Today is the first time we're going to show the virtual reality training in front of you. Darren and the team is going to show play that to all of us. And I'm really excited about that, how that's going to look like. But we also want to take an external view on this. We have invited Dr. Max Bell from Karolinska Institute here. Actually, he's going to be here in the office where I am in Stockholm today for a little bit of a discussion about what's happened in the ICU, what can be expected in the future, and also Baxter, our focus going into the ICU and strengthen our ICU presence in here. But I would like, and we also have our GBU leader, Brian Tufts, who's going to talk about, from a global perspective, what we can expect from an acute therapy point of view. But I would like first to say, this is now a much smaller meeting than yesterday. We can be more personal, so please use the chat, ask questions. We're going to try to answer as many as we can. Your name is going to be put there as well, so we're going to see. You cannot probably do it anonymous, which I think is a good thing. This is an open, transparent environment, and this is what we have created together over the last 3.5 years that we've been one team. The other thing is we have simultaneous translation, like yesterday. So if you haven't, when you went into the lobby, if you haven't entered into the agenda, clicked on the flag on the top of the slide with your country that you would like to have simultaneous translation on, please do that, because that could help you. With that, I would really like to kick off. And what could be better than showing this? I think this is an extremely result. And I'm focusing on the monitors placed and sold. Second year in a row, we are at over 1,000 monitors on the market that is placed and sold. Normally we do 400 or 500. I'm extremely pleased how this team have worked in an environment like the pandemic have forced us to do. The budget is the budget, but you see 10 million here. Actually, the true number should say 17 million. And let me explain why. Some of you may remember a year ago, nearly exactly, we got on top of our budget 7 million extra that we were asked to sell. This team did take that on and embraced it. I know there was some frustration, but you took it on as a team, made it happen. And on top of the 7 million, we delivered 10 million more. 10 million more on a business of 165 or 66 million. That is an extremely amazing achievement, and you should all be extremely proud of that. And I'm not only talking to the people who are on the field here, it's also about all the support we get from manufacturing, from technical service, from all the different functions around us. We are so dependent on you to make this happen. I would like you in the next couple of minutes just to reflect, listen to this, because I want to share some really great moments which you have achieved to make all of these numbers. Some are larger, some are much smaller, but they are all equally important. So just relax for a few minutes, listen to this, because you deserve to listen to what you have achieved in 2021. These 2 years in the pandemic has been really tough on us. it's also from a private perspective. Some of us have suffered a lot privately. Our customer have suffered. It's been a different way of working for us, and of course the patients in the end. I am extremely proud to what you have done and we as a team have done under this extreme pressure. Looking into this picture, I think with this extreme pressure, we have become a well-cut diamond that can make a difference for our patients and the healthcare professionals. And we can make things happen. I think we have proven in the severest difficulties conditions, nothing can stop this team from delivering the results. And this has not come for free. If someone thinks that COVID had made the result for this team, it's absolutely wrong. We have gone through whirlwind of quality things and supply part. I wouldn't say supply problem because it's actually the extreme demand that have caused that. That's why I'm a little bit later, in a few minutes, have invited Peter Jarvis to discuss those things, because this is on top of everyone's mind. You have shown that there's less talk, more action, and that is what counts. So I think this picture illustrates what we as a team has become over the last years and how we have performed and make these great achievements. So we talk a lot about team culture, best place to work, manager effectiveness score. These are all really important measures for us to see, are we in the top 25 companies or the top quarter that we're talking about? For some of these parameters, we are becoming a best place to work and a team that works as one single team. I really appreciate you challenge the status quo in the organization and in the Acute team and myself. I think that's the way, if we do it with respect, that's the way how we can build an even better team going forward. I think we build a strong foundation in the Acute Western European team, actually not only as expert in the CRT, but an expert in the ICU, in the intensive care unit. And I think that is going to be an important space for us in the future, with the Med-Del and Acute being one business unit going forward. I said maybe the biggest thing, or maybe not always the greatest, but I would say we talked about the 1,000 plus Prismax. That is a great achievement. What I'm going to say now is maybe the value of these are very small, but to turn around a challenge and make it happen on top of everything else, it's a symbol of this team, and also brings me to believe that we have a bright future together in the results that we're going to bring forward. If I look at the need of change from traditional sales approach, I'm going to take 3 examples on this. You probably could take much more. One is service sales. 200,000 is not a lot if you think about 166 million, which was the total turnover. But to turn around, take the challenge as each and every individual that you have done, and turn around something that we gave for free. The know-how you all have in the ICU about the CRT treatment and our treatments around Prismax and Prismaflex. We started to sell services, and we made the number we promised we're going to make. This number is going to be millions in the coming years. We have shifted gears on the value we bring to our customers, and they have seen it. This is the start of something really bright. The second part here is inside sales. Yes, we stumbled a little bit at the beginning. I think we have now, last under Prisca, got together and seen the value of our inside sales team we have. And who would have believed that you can sell monitor into competitive accounts from inside sales in collaboration with your field team? We have done that. Okay, it's only 2 or 3. We have 20 next year or this year, but it shows things are possible. This team can make a difference and do it differently. The last point here is the digital technology part. We have entered in 2 centers connected to the cloud with our TrueView therapy management. We have 2 centers that want to start. We have many more to work with. We know the journey takes time to get there, but this is going to be a differentiator. This is going to be in value, and we're going to hear more about that later in the Talk the Walk sessions. So great achievements for those who are behind all these things, and 3 things that makes me really trust that we're going to deliver any number that the company will come up with. In an environment like this, we also managed to launch Prisma Lung Plus. I know there was a lot of frustration in the beginning about the restriction of who to sell to, which countries. We handpicked a few countries, a few centers to really make a control launch and understand the product together with the medical team. Yes, there was frustration, but if you look at the result, 8 months later, we have 72 centers who have bought Prisma Lung Plus. 196 treatments and more than 100 patients has been treated with this. We have overachieved our target with 54%. This is a phenomenal launch. Talking about launch excellence, and I think Joe always narrates that we need to be good in launching new products. This is really launch excellence. So congratulations to each and every one behind the Prisma Lung launch. I said before, product supply constraints. This is, of course, have colored even 21 as they did in 2020. But what I've seen is this. In the beginning of the pandemic, 2 years ago, we were not as friendly or frequent sharing our products with each other. 21, that totally disappeared. People raised their hand, I can share this volume, this product, and we move them around to manage to treat each and every patient and secure that the customer stays and rely on Baxter as a supplier. Has it been easy? No. Has it been with some tough discussion? Yes. But the voluntary among the team to give up products to serve another country to make that happen is there. And I'm extremely proud of that. I think that shows as we are one team and we're united to serve our mission. And I think with this, I would like to also introduce Peter Jarvis, our Vice President Operation on EMEA, talking a little bit more about the supply constraints and the quality issues we have faced in Acute. So really welcome Peter up on the stage.
Magnus, thank you, and it's a pleasure to be with the Acute Therapies team today.
Thanks. So you and I discussed a little bit. You were on our town hall 9 months ago, talked about the capacity versus the demand and all of that. And I think it would be fair to say that, yes, we have worked a lot with supply, extremely hard. And some people may say that we have a manufacturing issue. I would say the demand, we can never meet the demand on a global in a pandemic like this. We can never build our footprint to that. But what can we see? We have done a lot of things, and I would like this team to understand how we are getting the basics right when it comes to capacity and how we meet the future from that. So what can we expect?
Magnus, thank you for the question. And I thought we might start with an easy question, but this is clearly one of the most difficult. Before I get into the detail, I really hope the team doesn't mind that I just take a moment to have a very quick reflection on the COVID challenges and what it means at a plant level. For the plants to operate, we need the people on the line. And clearly we have a duty to keep people safe. People that are very anxious to even travel into work and avoid the risk of COVID or mitigate as far possible. That is difficult, and it has continued to be a challenge. What I can share is that we have had 0 known cases of COVID transmission in any of the EMEA plants. And this is for people that do not have the opportunity, the option to work from home. they have to come into work. So I really did want to start by recognising the people first. Now, in terms of the specifics of capacity versus demand, ISC, Integrated Supply Chain, have shared the frustrations. It is very challenging for us. These are difficult conversations, and we are not at all comfortable with the fact that we are capacity constrained and that we can supply more, we can sell more, and we can serve more patients. That's not a great place to be. In an ideal situation, any manufacturing company would be able to meet changes in demand, both increases and decreases, very, very quickly. That is not the reality. So what are we doing to increase capacity specific for acute? Let me just get into some detail. Until 2018, Sondolo in Italy was the single source of acute solutions for Baxter. In 2019, we increased capacity by adding Castlebar into the mix, and that gave us an increase of capacity in the region of 25%. At the same time, we had prepared and started to execute a longer-term strategy to meet the LRP demand with solutions made in region for region, and adding a new acute line in Mexico, in Cuernavaca. That line comes on stream imminently. We've just completed first off code, and we are now supplying bags from Europe to Cuernavaca. On top, there has been an investment in a Kiefel, the machine used to make bags, for the Cuernavaca site, and that will come on stream later this year. As we look across the globe, there's been another capacity expansion in China. First off code there will be early 2024. If I switch from solutions to sets, Malaysia has significantly improved its output. We're up by 15% in one of the key measures, and we're also increasing the supply of components for those sets into Malaysia from both Tunisia and Malta. So, Magnus, quite a bit of detail there, but I hope it gives you a feel for the actions we're taking and the way that the system works.
No, thanks, Peter. I think it's important for this team to understand that we're not leaving acute alone, that we actually as a company are investing in this. And we are maybe the smallest business unit, with one of the most profitable one, and working with really critical care patients. So I think this is building, at least to me, confident in the future being in the acute space. I also know, as you said, we are moving a lot of the manufacturing into European soil. There's very few things in acute which is outside of Europe. Moving the monitor Prismax into Medolla from Brooklyn Park during last year. So I feel that we are on the right track, and I hope just the demand goes down to a semi-normal level at least. Then we will not focus so much about supply part. We can focus on other things. But thanks for giving that. I hope that gives a little bit of relief and room for the team as well to understand that where we are and what we are investing in. Another thing that I thought about was the relying on third-party capacity. Okay, why don't we want to do this in-house all the time?
Yeah, Magnus, as a manufacturing guy, as an engineer, I would love to make everything in-house and to have everything vertically integrated. Having said that, the use of third-party capacity is completely normal. So if you look across other industries, for example, Apple, and I think many people have just seen their latest results, Apple manufactures very, very little internally. So why do we, Baxter, use third-party capacity? There's a number of reasons here. One is to balance cost and expertise. We wouldn't want to be subject matter experts in every single thing that we make. Installed capacity, it's not free. Equipment is not free. Expertise is not free. So the best strategy, the most optimum strategy, is to really focus our investments and our skills on our core products, on our core skill sets. We don't want ever to rely completely on a third party. That would be significantly overexposed in terms of intellectual property and expertise. In terms of the current global situation, where demand is outstripping supply, you don't want to be reliant on those third parties and competing for capacity at third parties. So where it makes sense, we produce in-house. Where it makes sense to vertically integrate, we're doing that, and we have a number of projects currently underway to bring some third-party components in-house. For example, moldings on sets, we're doing a lot more internally. But we will never be completely internal for manufacturing capacity.
No, thanks. And I guess if we were, we would maybe have a too big footprint on manufacturing if the demand goes down. And then you will have me complaining to you about the COGS as well. So
absolutely.
I think that's also part of the mitigating the risk here, or limited as well. So
yeah, absolutely.
Good, thanks. Last point, Peter, from my side to you. This is, of course, evident that we have faced quality issues with our Prismax and TheraMax since we launched 2.5 years ago. We have moved our manufacturing to Medolla. We have launched the 3.1 software upgrade, which has improved the situation, but we still face this. So how do we secure reliability and high quality on this platform? Because that's what we built our sales on.
Yeah, Magnus, again, I'm going to divest just very, very quickly as we talk about parts supply. Right now, I think we are facing an unprecedented situation, particularly with regards to the supply of electronic components. So today, the biggest issue we have is electronic part availability, combined with global freight challenges, and we are doing our utmost to work through that. Now, as it relates to the quality, you're absolutely right to mention the transfer to Medolla, because that was an opportunity to drive some changes into the system. We have added supplier development resources, particularly in the Asia region, where we're sourcing a lot of the electronics. So those people are working with suppliers to ensure that we're getting the optimum quality. All of the supply chain was completely revisited on the transfer to Medolla, and today we are still executing some supplier footprint changes. So, for example, there is corrugate today, comes out of the US. Within the next 3 weeks, that will be sourced locally in Italy. The electronic systems were all adopted for the Medolla material management using the bill of materials, incoming inspection systems. And that was fundamental to ensure that we're mitigating the risk of part mix-up, etc. There was a systematic review of the so-called PFMEA, which is the process failure mode effects analysis. In simple terms, this is a system that looks at the things that can go wrong and puts in place either foolproofing to stop it happening, or where foolproofing is not possible, we'll add extra inspection techniques to, again, mitigate the risk. So I'd love to go much deeper on this, Magnus, but time won't allow us. But I can assure you that there was a lot of work done and a lot of work ongoing to drive these needed improvements.
No, thanks. Because I think we are sitting here every day, and I know I also want to thank Dimitri Paz from Benelux, who taking on this to get feedback to the R&D and the global GBU as well on what we see on the field, because I think together we need to highlight what we see, and then we need to trust that those things are fixed as well. So I think that's the only way forward for us as well on how to improve the quality on this, and we need to get there one day, and there is a lot of people behind all this.
Absolutely.
Thanks. I don't know if you had anything else, Peter, for this team.
I would make one request, if that's okay. And I know that we have a lot of tough discussions on supply and quality and capacity. One area where the team can help supply chain is on forecast accuracy. The higher our forecast accuracy, the better prepared we can be to adjust in a timely, cost-effective manner for actual demand. And that goes both ways. So if we call down a forecast, I'd love this team to be aware that that has implications. For example, if the forecast falls and we have too many people to produce too little product, we will right size our headcount. If the demand then spikes very quickly, we need to then recruit new teams, train new teams, and put in place that increased capacity. So the bottom line, the higher our forecast accuracy, the more enabled supply chain to meet actual demand. So that would be my request.
Thanks. No, and we know how important this is, because that's the output and how we divide the products between the region as well, and between the codes we are having. So point taken there. Although we must say the demand in a pandemic is not easy to actually predict, but hopefully we're now getting out of there and we can be more precise on the demand part.
Yeah.
There has come some question. There's two questions. I think it's more or less the same question, because it's about the auto effluent. So one is, well done with the integration of supply chain sides for sets and fluid, but we have seen big challenge here of auto effluent set and transfer of production side. What is the lesson learned?
Yeah. We always will do an after-action review specific to such topics. Frankly, one of the biggest issues with the auto effluent set has been the availability of sterilization capacity, and that may have been a challenge regardless of the transfer. I think in terms of lessons learned, what we do need to be more critical to is on producing the so-called bridge volume. So from the end of production to the start of the new site, do we have the sufficient safety stock in place in the right area to enable fulfillment of orders? And that's always a difficult one, but it's one where we need to take a holistic view, not just looking at the cost of inventory.
Okay. Because this is the auto effluent has been, of course, it's on everyone's mind right now. So I think that's, and we have another question, similar one, but I got to take two more questions before we need to move on. So how long does it take to validate new manufacturing sites?
Yeah, this is not an easy question to answer. I'm going to take it two ways. In terms of a site, that would depend if this is a transfer to an existing site or it is a new site startup. Rule of thumb for a transfer, depending on product complexity, I would say we would start around the 18 months timeline. If we have regulatory impact, that extends out to up to 3, 4, even 5 years, I've seen.
Okay. I think there is a last question here as well. Peter, thank you for the update on the electronic part availability and unprecedented situation we are seeing. What advice would you give us to advise our customer on Prismax availability?
Again, I think the advice is, if you see a demand coming, place the order soonest. because this situation is absolutely unprecedented. And to give you a flavour for the sorts of actions we're taking, I am spending personally around 2 hours of my day working with the Madola site and their suppliers to overcome the challenges. Last week, Friday, I was talking to a supplier in China at the level of the owner. The companies that we're buying from are also challenged by the availability from what we would term the OEM, the original equipment manufacturer of the electronic components. Here we talk about people like Toshiba, Matsushita. What are we doing with these people? We are leveraging functions like GAP, government and public policy, to ensure that the likes of Toshiba are aware that these components are being used in medical devices. They're not going into an Xbox, which would be absolutely inappropriate in the current environment. So get the orders in early, and please be assured we are really pushing on every aspect here, from the supplier to the government to the OEM.
Thanks, Peter. I think that this brings clarity in the situation. And I think in a situation like this, both supply and quality is important to embrace to the team as well, to we understand. But this is this is on top of everyone's mind. And I know we in the leadership team, and we have addressed it to Joe in the last QRR that we had, the quarterly business review we had with him as well. So it cannot go higher up in the organization as well. So I'm really happy to see the things we've done here and what we are doing, but also that this is a key focus for the company. So I'm really looking forward to the future here to come out of this. So really appreciate taking the time, Peter.
My pleasure.
As always.
Thank you.
Good. I hope that gives the team a little bit more hope on where we are with the supply and quality part as well, that this is really on top of everyone's mind, and we're working very, very hard on getting this sold and getting the basics right here. Let's now shift and leave 21 and shift into 22. I will ask Christian Rabets, our finance director, to come and talk a little bit about what is our new year, what is the opportunity for the new year, and what should we achieve as a team together? Christian.
Yeah, thank you very much, Magnus. And also from my end, good day to everybody. So maybe just before I get started, I also wanted to take a moment to recognize all of you for the outstanding performance that you delivered in a year where we did have numerous challenges. So really, also from my end, congratulations for a job really well done. Now, so let's switch gears, right? So and look ahead to 2022, and especially here, our wildly important goals, because in a way, numbers are numbers, but you gotta chart the path how to get there, and this is where our wildly important goals come into play. But before I get into those, maybe just a few other thoughts on sharing on what our AOP is really all about. So our 2022 AOP is a non-COVID AOP. So contrary to last year and the year before, where we had substantial sales that were really like COVID induced, we do not have these kind of sales in our 2022 AOP. So no COVID sales. That's one really important thing to mention. But, and this is also, I think, true and important to know, COVID, and of course the ripple effects from COVID, are here to stay for the foreseeable future. And these ripple effects, they're not just bad. So there are challenges, okay, of course, but also there are opportunities. And some of these challenges are actually, I think, also disguised opportunities. So let me start sharing with you a little bit of my perspective on opportunities. So as you guys were saying, and you were already talking about food supply, I would predict, considering what Peter mentioned in terms of additional capacity that's coming online, our demand unit is declining year over year by 10%. So I think with that, given all the capacity we're adding, it's a pretty good bet that we will not have as many challenges with fluid supply as we used to have in the past. And it's good news for us, right? Because it frees up time that we've used to manage orders, manage customers. So we'll have a lot more time to speak with our customer about other things. So what else is there, right? So on the positive side, I would continue with, and this is really great, yeah, because the situation in the ICU is actually quieting down. Furthermore, and considering that Prismax is our workhorse, we have an unprecedented number of devices in the field today. And finally, we delivered significant amounts of training, really broadening the knowledge of CRRT and OST overall. Now, of course, and I'm talking COVID specifics, right? There is a big downside, and that downside is that the hospitals today have less staff. And that is for numerous reasons, and you all are aware of why that is. But I would say overall, it would feel like, as far as COVID-induced ripples are concerned, we may actually have more opportunities than challenges. And with regards to these challenges, I mean, I would even say, and I alluded to this, so maybe there is a hidden opportunity here. And Magnus talked to the significance and the importance of services sales. So hopefully our customers see the value of training, and they see the value of flexibility, especially in light of a situation where they don't necessarily have enough staff, or they haven't, so they don't have enough staff. So maybe we can therefore turn this challenge into an opportunity for us and build momentum to pave the way to sell our digital solutions and education services. So Magnus talked about the $200,000, so that will certainly not, financially speaking, is not a big deal. But as Magnus said, it's a really big deal for us as a business, because we previously thought we wouldn't be able to sell this. So next year, or this year, 2022, plan, it's a bigger number, but still, it's not a number that's going to make or break our AOP. So it's important, but it's not super critical for our AOP. Now, it is super critical in order for us to get on that trajectory so that we can actually hit our long-term growth aspirations. And that is why, when you look over to the right, why we included this in our wildly important goals under the wildly important goal number 6. The other element that is important when we think, and now we're getting a little bit more tactical in terms of delivering on our sales and on our operating income that we promised on, is that we need to continue to focus on profitable growth. And that means for us this year, first and foremost, we need to be hitting our sales numbers, our AOP sales numbers for Prisma Lung and for Osiris. These are high margin, high growth sales targets that we've set here for us. So it's a pretty good bet, a pretty good chance that if we start missing on those, we're going to be starting to miss on our plan, not just top line, but also really on the bottom line. And we've seen some of this last year already, where, here and there, we managed to then prop up the top line with device sales, and I think we all appreciated that. But in terms of profitable growth and really showing, that we translate sales and revenue into cash, so operating income that we can use to invest, that's going to be key. So hitting our AOP for Prisma Lung and Osiris, as you can see, we got wigs number 1 and 3 slated for that. And finally, and this is something obviously we cannot turn our eyes from, CRRT sets and fluids still represent a dominant part of our sales. So focusing on that, so by driving adoption of existing therapies and therapy enhancements is another important element, essentially leveraging our existing portfolio to make sure that we can deliver on the top and the bottom line that we have signed up for. So to sum it up, so why are those wigs important? Ultimately, they're important because if we don't really have a good plan, and so we'll miss our AOP. A good chance we would. And in addition to that, and this is a bit more away from the tactical bit, but our wigs are the key to increase our revenue per device. And why is that so important? Because when we do that, it does help our overall profitability as a business. And when we are becoming more profitable, then this enhances our attractiveness as a business, because in the end, one of the things that we need to always be bearing in mind is we're competing for resources with other business units. So if we want to be the prettiest bride, that will be one way of achieving that. So with that, I'd like to close. Thank you very much for your time, and good luck from my end for 2022. I'm sure I'll see and hear a lot of you during the year, and I'm looking forward to that. And I'll turn it back to you, Magnus.
Thanks, Christian. So I think it's important that we keep, and you see the wigs continue to nearly be the same as they were 3 years ago. And that is our key driver to drive profit and growth as well. So thanks, Christian. I just wanted to take a few minutes to talk about what has been announced over the last couple of days. There is new opportunities, as always. 3 years ago, we changed the structure. Now we go into a new business unit setting. So why do we have medication delivery, acute therapies combined? You can see the number here. This is going to be a fairly sizable business, somewhere between 450 and 500 million dollar business. To the right, I'm not going to talk to that. You're the expert on this. If we look at the care setting and the importance of bringing all of this together, the MD part that's going to follow to acute together and be one business unit is going to be the solutions, so the IVs, irrigation sets, together with how we monitor this. So the Starling monitoring. This is going to be how we measure fluids and sensing around those things. That's a critical thing for the balance in the ICU, in the med-surg area. And together with the pump and syringes, that's going to fulfill that portfolio in this space. So this is where you can see this is the new MD acute therapy combined portfolio that we're going to carry into the future together. So why is this so important, and where do we focus? So let me do like this directly. Our main target is going to be the intensive care unit. As said before, this team is highly specialized in the ICU. You're the expert here. We also going to have a big presence in the med-surg, so the step down, step up units around the surgical units. That's where medication delivery together with intensive care has a broad perspective and a broad footprint. Together, we're going to build all of that together with the connectivity piece. Because in the future, it's going to be improved. We have just scratched with the TrueView management part, therapy management part, the connectivity across the care setting. That's what we're going to build together. And the value of that is, of course, to reduce reduce risk of complications, to connecting all of this and tailor it for the specific ICU units or med-surg units that we are having. So this is actually the value we want to bring together. You see all the products below here as well. You also can think that we have hill room products, like in the frontline care, patient monitoring about workflow, sepsis management. There is also in the patient system support, the PSS, smart beds and surfaces that also deliver data that can be analyzed and bring value for the caregivers and the physicians and nurses to make decision at point. To me, this is a really attractive space to be, to build a strong value proposition in the critical care together, MD and acute. That is really tangible. So what is going to happen? You're going to hear more about this, but what is going to happen over the next coming 8 weeks? And I think it's important to be as transparent as possible. Cristiano already said yesterday, the new structure should be operational by beginning of April. So that's the timeline we have. Myself and Andy Goldney, who is leading nutrition and pharma, has worked closely together over the last couple of weeks about how we're going to structure this. My intention is to bring a new leadership team together in early March, somewhere in the second week of March or third week of March, to build, as we did when we built together the strategy, the KPIs, the org design, the governance all around that. We're going to build exactly the same thing, but now for the combined MD and acute therapies. This is not a one-man show. I just want to point out this. This is something we're going to do together. We're going to build it together. We're going to execute it together. So just to give you a little bit of timeline, we would like to announce the next layer earlier than the mid-March that was said yesterday. I think that is, Cristiano and myself and Andy is totally aligned about that. I think it would be good to do this as soon as possible. So, and then bring the strategy and the footprint or the organizational design in March so we can start executing in April. That is a pretty aggressive timeline. But I know there's also anxiety in the teams about what will happen, what will I do in the future. I would say if you're in the sales, if you're a therapy specialist, if you're an account manager, there's going to be limited impact on this. We need the footprint on the market with our customers. We need the expert, as I said before, we need your expertise in the ICU and spread it along a broader portfolio. Just wanted to give you this, and I'm going to continue to communicate around that to you and the MedL team over the next coming weeks and months, just to keep you in the loop on where we are in the different steps forward. And I'm really excited and of course really happy that I had the trust to lead this organization going forward. So I'm going to do my utmost to deliver also from a personal perspective and respect the impact on each and every individual going forward in that perspective. So just wanted to give you a little bit more glance on this from yesterday and the announcement on Friday. Much more is going to come in the coming weeks around that. What we're going to do now, I'm going to walk over to another room and have a discussion with Max Bell from Karolinska University Hospital here in Stockholm, Sweden. I please ask you to post questions in the chat. It is going to be important. We're going to have a fairly long Q&A session there as well. I have a few questions that I'm going to address to Max Bell, but it's also your session to ask questions to Max about the future ICU, CRT, whatever comes up in mind when it comes to this. So give me a few moments and I will be back. Thank you.
So now I have time to change room here. So Max Bell, some of you probably know him very well from either Baxter education, lectures, conferences, and so on. But Max divides his time between working as a head consultant in the Karolinska Central and Neurosurgical ICUs and doing clinical research in the field of perioperative medicine and intensive care. Specifically, he has done large-scale studies on AKI and CRT, investing biomarkers of both kidney injury and function, as well as studies of RRT modality. He's currently the PI of a multi-center ASAC study with over 180 centers enrolled. He has tutored several PhDs and is currently the main tutor of 3 PhD students. So very, very welcome, Max, to us today.
Thank you. Glad to be here, honored. It's going to be a interesting conversation, I hope.
So we're going to talk a little bit, you and me, but there's also going to be questions from the audience.
Sure.
So first, evidently, not talking about COVID and intensive care. This has been, of course, put a lot of focus in our society over the last 2 years.
Right.
And you as an intensivist, what has been the biggest challenge during this time?
So I feel that there's been a multitude of challenges, and some of them are, I guess, like specific to Karolinska and regional, maybe even specific to my department. But some of them, I guess, are more generalizable. We were faced with a large-scale surge of patients almost 2 years ago in March 2020, and we have been warned, by the developments in Wuhan in China, and more specifically in Europe, in Bergamo and other regions of Italy. So we had some time to prepare, but it was still a large surge of patients, and that put a quite extreme strain on the healthcare system in general and on the ICU in particular, and it put a strain on healthcare workers like physicians, ICU nurses, etc. And I think some of the topics that I know we're going to talk about today are like directly related to those to that period in time, at least the first couple of months, but elongated even into like the summer of 2020, put like a dent in the healthcare system that's pretty evident with people changing their jobs, maybe not stopping being nurses. Some of them just change leave the job altogether, and some of them choose to change their ICU nursing to something else, something less straining. So it was a great challenge. It was a personal challenge. I had to and other senior physicians, researchers, you had to basically give up research for a while, whilst sort of in the back of your mind also considering the fact that this also needs to be researched, this condition, this new disease that we're seeing here. So it was a stressful time for all of us, and I think I personally made a conscious choice to put research aside for a while, and also put ICU leadership aside, because I wanted to work bedside with the patients, and I did that for a couple of months, basically doing long day and night shifts for maybe 3-4 months continuously, just 13-hour shifts, day night. So it's tough.
But we have seen, you talked about the early phase of COVID, but this has also changed over time.
Oh,
we learned a lot over the first couple of months, and it also changed a lot when we see, if we focus on CRT for particular. Sure. In the beginning, we saw figures about nearly 25% in the ICU needing CRT, which is now below 10 or even lower.
Yeah, I agree. I was tasked with sort of assessing how many CRT machines do we need at Karolinska, and we quadrupled our ICU beds, and would we need to quadruple also the CRT capabilities? And it was really difficult in the beginning because there was some data from China with like very low percentage of CRT use, like 2%. And then there were some reports coming from Italy where, yes, the numbers like 25% and higher were sort of reported. So it was difficult to assess. And I agree that the virus changed, and how we treated the patients changed. And some of these small tweaks in treatment with regard to higher anticoagulation strategies, etc., might have also had an impact on the need for CRT. So yes, I felt that it was extremely dynamic in the beginning, and now it's I'd say with the current Omicron surge, it's not putting that much strain at all on the ICU capabilities.
So would you say now, if we're going to look forward a little bit, and
Right.
would you say now that this is more like a normal influenza type, or is what
Yeah,
you expect from an influenza?
Yes, I would say that, and I mean, this is the million-dollar question for health management worldwide now. And I know that Denmark is like, for instance, not anymore considering this a dangerous disease in that sense. So I would say that this is like a severe cold now, Omicron. For the vaccinated, it's a non-severe. It's not a killing disease anymore. Even in the elderly, the so-called SABOs in Sweden, where really old people are, they do have Omicron in there, but those patients are triple vaccinated and they're not dying from that disease. So influenza in that segment of the strata of the population is actually more dangerous. So it's but again, it's a soaring disease, and unvaccinated might run the risk of getting severely ill, of course. So it's not nothing with regards to strain to the healthcare system, but it has more to do, I think, than with hospitalizations and maybe not so much in the critical care units.
So some of the surgical procedures, they were nearly stopped during at least the first wave, and also I think in some countries we saw dramatic increase in surgeries. How do you see that? Is there now a big backlog that you need to?
Well, it's so I'm aware of that, and actually, if you look at the Swedish intensive care data and the anesthesia surgical data from Sweden, it's not that it was impeded, and we do have a backlog, and Karolinska's had a focused effort on doing elective but important surgery during weekends. So we've had like 1,000 patient backlog, but with extra surgeries done on a extra basis on Saturdays and Sundays, we've been managing to cut that backlog. It's like less than 25% left. So it had an impact, and those health effects are hard to gauge, and I actually do think that the only way to gauge those effects are with these studies that are coming out now, where you look at all-cause mortality in different countries. That's the only way to gauge the effect of, like, with the severe lockdown, with even longer backlogs, have an impact on surgical outcomes, like some kinds of surgeries that were really stopped in some countries for a long time, whereas in Sweden sort of trudged along a bit, and then we didn't have that full lockdown. So, and those effects will take, like, I guess, years to fully evaluate. But that's an effect of of the disease as well. So it's hard to gauge now, but in a few years' time we'll be able to understand more, I think.
So you talked in the beginning about nursing, the staffing. We hear that all the time now in Europe and also elsewhere around the world. That nurses are leaving, maybe even physicians are leaving.
Yeah.
If you look at a company like Baxter, so okay, you're quite familiar with Baxter and the support. What advice would you give us, and where do you see us in that space,
right,
helping out in the situation?
Yeah, full disclosure, I got this question beforehand. I really tried to think about it, and it's hard not to just come up with cliches. But I think what I sort of wrote down as like some memory tools for this conversation was like, it has to do with all participants in the healthcare industry pulling together, because I mean these changes in how personnel see themselves in the healthcare industry, those changes started way before the pandemic, and then the pandemic was some kind of extreme trigger event that understandably triggered some people to actually quit the healthcare industry as a whole or change course within the healthcare industry. And so how do we address that as participants from hospitals and or governments and private companies? And the sort of rambling answer is, I guess we all have that kind of responsibility. I wish I could say that all manufacturers of medical equipment and all pharma companies would see their role. The fact that you asked me the question is, I think, good. It's really good to have a big company like Baxter asking themselves, how can we assess and how can we later, when we've assessed, help? And my concern is that not all companies are doing that, because if we all pull together and think about how we can sort of increase the the well-being of the healthcare workers, then we might, because it's also a quite fun job.
Yeah.
I mean, people choose it in intensive care specifically because it's a whole lot of action and it's life-saving and it's fun because it has those dramatic parts, but it's also quite draining and tough and stressful. So if we can sort of help to address those bad parts about it by being looking at salary levels and how much people work, and if you could increase the nursing salary levels a bit, maybe you could have a few more nurses being attracted to the job, and by doing that you could have more heads would cover the 24-hour space that we need to occupy, because we need to be going 24/7. But if we had some more people working there, you could have better schedules for people, and that in turn would get the lifestyle for these nurses and physicians to be a bit improved, and then you could sort of tweak this like bad spiral into some sort of good circle instead. So, but it's hard to be, you need to look at scheduling and salary levels and off time. But to change this like freight train that's going in one direction, which is like less people are working and those who are still working need to work more shifts and more hours, you need to change that. And I guess you need to look at, all the stress factors in the job, and help. If all companies would pitch in and sort of try to address those things, that would be beneficial, I think. But it's hard to be really, really.
But if you look at, you said nurses leaving, so we have discussed a lot about how can we be more flexible as a company when it comes to education, because there's no new nurses coming in, and I know you had a special scheme in Karolinska about when should you start CRT, how long do you need to work as a nurse before that, and of course we see a place there that we can be help you more than others in the ICU when it comes. We're just launching a virtual reality. We're going to talk more about that later today. Virtual reality, where you actually can do the training on Prismax and modalities whenever you want.
Right.
Without the monitor.
I mean, and that will be. I mean, this will be to really address fully this issue of nurses and physicians quitting their ICU job, which could be really detrimental for the society as a whole. So we need to address it. It's a real issue. I do think that educational capabilities, where big companies like your company would pitch in and sort of assess and see how they can help, will have an impact, of course. So, and I mean, you and I talked before about at Karolinska we were quite rigid when it came to how many years you had to work as an ICU nurse before you were sort of allowed to do the CRT training, because we needed to have really, really well-trained nurses. But now we might have to change that up a bit. We might need to tweak that and have the nurses start those kind of advanced trainings with your help a bit earlier, to keep the job fun and to like keep everybody on the toes, and actually to have those new nurses coming in being sort of fully capable nurses, so that they can actually give the full range of treatments that we need at the high level ICU that we're having.
Another thing that you and I discussed a little bit before, and that was the digital equipment and how you get constant or instant feedback about that. You said to me that earlier that EMRs, through your EMR system, or PDMS system, you need to go in and get that feedback.
Right.
How is your view on digital equipment in the ICU and get instant feedback from that?
I do think that we have sort of a problem here, because I don't think the manufacturers of EMRs, electronic medical records, or PDM system, patient database management systems like we have in the ICU, and or manufacturers of CRT platforms, respirators, pumps, etc., have fully realized that actually in their hands, you all have the capability to give like automated reports back. That could be done quite easily, and I think it's sort of been totally lacking. So one could envision a feedback loop that would sort of log that this user, nurse X and physician Y, they've been treating these patients, and at the end of the month you get a report like it wouldn't be like this was a good or bad job, but just a informative report on outcomes, etc.
Yeah.
And you can then you can turn it into research and tweak, look at associations between what you did and different outcomes. But it could also be seen as educational, sort of a tool to easier be on your toes when it comes to learning new stuff and tweaking your old habits, etc. Because people, of course, they stick with their own old habits, and but this could be an easy, I think, and really a doable way of getting that sort of information loop going automatically. Now you sort of have to do it on your own, basically. It's not structured in any sense, really.
So we have a question, our first question here as well. So I will just put it in here. So in comparison with pre-COVID, would you say that the virtual interaction works well? And are there certain venues where you believe that the virtual interaction works better for you as a physician versus face-to-face? And I know you were on a virtual interaction, was it last week for Baxter as well?
That's right. So I had a lecture for Baxter in Malaysia. It's a pre-recorded lecture. I will have a live Q&A early in the morning in a couple of weeks in Malaysia. Because Malaysian time that's early in the morning for us in Sweden. So that kind of works. And I'd say that some of the unnecessary traveling for environmental reasons are a thing of the past. That won't come back. It will be very, very beneficial in the future to have a meeting like this. You and I could potentially sit on a stage in front of 400 people, do this talk live, this fire chat, which is, this is almost as good. Whereas in other circumstances, some of the pre-pandemic times, with regards to like conferences and research presentations, I do miss those times because it has something where you can, if you're part of the faculty, you meet other people in the faculty. These haphazard at the bar or at lunchtime meetings actually do create they create creativity. Sparks of creativity happen when you meet other people live, and that's not as easy when it comes to a Zoom meeting, etc. So it was a trigger event for much more structured e-meetings, telemedicine, etc. That's good, but some of I think that's beneficial for the environment. A lot of unnecessary airfare gone, good, fine, but also some of the true human interaction is hard to replicate. Yeah. Even if we had, I guess the vision of like the meta world, etc., is that we will have closer to that with like advanced avatars, etc. But I think it's far away.
Yeah. No, with the lack of staffing and the high pressure you have in an ICU, of course, we are working with a lot of innovation. So right. we just launched Prisma Lung Plus, for example. Just taking one example. And how do you see that with that lack of staffing, all of that? How do you see you embracing that and taking that also in your daily practice?
Yeah, so that's a challenge, and I don't have a definitive answer. But so I guess with better training modules, etc., we could perhaps overcome that. But I do think that's a worldwide challenge. That if you have a high turnover of staff, that will not only will it create problems for the singular patients that are treated in your ward, but it also creates a problem with regards to training, because, and I've had this very discussion with representative Baxter, talking about, for instance, Prisma Lung and other new technologies where I could truly say that, not now, guys, we need to train the new nurses to just do the regular job, and unless you have that sort of stable base staff of good ICU nurses and physicians, it's hard to incorporate new techniques. and it's hard to do good randomized controlled trials or other observational trials. So it impedes research and education both. But by improving the interface for learning and e-learning, etc., I mean, we could at least try to address that a bit. But we need to basically turn this around, and I think that's doable.
Yeah.
I still think it's a profession that will continue to attract young people, and keep young people working in the healthcare industry. But we need to address some of these major challenges.
Because that should do your job a little bit more fun and interesting as well, taking on all of these innovations as well, to attract people to stay and maybe even attract new employees into
absolutely. So there's a conundrum here. It's so much new people that we can't allow them to learn too much new things, and that in itself makes the job a wee bit more boring. And so it's actually, we need to be sort of proactive and kind of brave and say okay, yes, we have a high nursing turnover or staffing turnover, but still we need to keep going when it comes to research, learning, innovation, etc., because that's also what keeps the job interesting. And so that, again, that's it. It's partly mindset, but it's also a fine line to walk, because if you would have, if you try to be empathetic and a new nurse comes to a high level new ICU, he or she has a lot to learn, and then to 2 weeks in, oh yes, and we're also introducing this new thing, that can be overwhelming. So we need to sort of walk that fine line.
On that, biomarkers.
Right.
How do you see the place of biomarkers in the CRT space specifically, of course, because
exactly.
That's where we have an interest.
Oh yeah, me too. I mean, like you said in the presentation, I've done a couple of studies on injury markers, specifically NGAL and NephroCheck, bioMérieux, NephroCheck, TIM2, and IGF-BP7. So those are markers of AKI, acute kidney injury. And then I've looked at cystatin C, which is a functional marker, but that we feel complements the use of creatinine, urine output, and urea. So, and sometimes and there's a lot of interesting findings coming from my group and a whole bunch of researchers, and some of the ADCI meetings recently had to do with biomarkers and how they're clinically applicable. But I do also feel that in 10 years time, I've always said to maybe a Swedish or Scandinavian audience, within 5 years, I think you'll have these tools at your disposal. But it's like going to March, it's always 30 years away. I feel that I've pushed this away those 5 years. I haven't truly seen a lot of clinics incorporate new biomarkers of injury or use functional biomarkers. And there's ones that you see, there's PenKit and other functional markers that are potentially interesting and could potentially sort of elevate the level of care. And I do think that has to do with the fact that clinicians all over are sort of unsure how it would practically impact their choice for CRT treatment, to start it and when to stop it, like weaning for CRT. So, and that in turn has to do with the timing studies that I personally think are sort of hard to understand because they are done in different circumstances, and some of the big French early versus late CRT studies are actually not only looking at CRT, they're using a lot of IHD.
Yeah.
And so they become sort of hard to at least use in a Scandinavian or Australian context, where CRT is like the sole method we use in the ICU. So it boils down to the fact that it's hard for ICU physicians, I think, to see that novel markers of injury and or recovery and or function will markedly improve how they go about doing things. And the only way around that, I think, is to actually try to start using them anyway. Because when PCT, procalcitonin, was introduced way back, people were also like, well, we do have CRP and we have fever and we have, white blood cells. Why do we need another marker of inflammation, infection? And some people still question it, but I think in some certain cases it actually does help you in determining if this is a bacterial or viral disease, etc. And introducing biomarkers, if they were a bit cheaper and if they were more readily available in more labs, people would start using them, and you would sort of, even without targeted research, you would sort of understand within the clinical ebb and flow, well, in this case, it actually helped me decide to start CRT. And NephroCheck, for instance, has some of those examples, like, this is a high-risk patient undergoing high-risk surgery, and she's old, and you would expect them to get an AKI that needs CRT. And sometimes you could look at markers, but actually, no, there's no injury stress here on the kidney, so we could wait. So, and in other cases, you would not expect the need for CRT, but you would see that, wow, this patient really has an elevated level of injury markers. We should probably think about CRT earlier than we would have otherwise. Yeah. So my rambling explanation has to do with the fact that I think people don't really understand how they would practically use them for true clinical purposes.
Is it also a timing thing that you need to send it to the lab all the time and wait for that? Would it be a difference if you had it in your ICU unit and you instantly could take that?
Some of these markers are point of care markers, and you do the reading within the unit on a machine, and maybe there's a lag time of like 15-20 minutes. Yeah. And so I think it has more to do with the fact, I think it's usually easier to send things to the lab because you will get, it will be validated and done properly. When you do it like in-house and it requires some pipetting work, that's impediment, I think. So I just think you need to get it out there and get it going, and sort of, if I were companies that personally, try to sell those markers, I would really start them at lower pricing to get people to have an uptake, and then you get to know the marker, and you get used to using it, and that's when the ball starts rolling. But also more research is needed as well.
Oh, it's an interesting thing, as you know, we're also going into the prevention space with the nuclear. So
exactly, and I think it's. I remember talking to Baxter representatives way back when NephroCheck was new outside the arc. This could have market value for you. The fact that we have another, marker of injury here. It's not a troponin for the kidney, but it's something in those ranges. Should actually help people be more aware of AKI, and thus be more aware of potential treatment, i.e. CRT. So again, I think it's wise of you to be in this space and try to keep informed of what's happening in that space, because it will have real market value for you to know it. And yes, it has both to do with avoiding long-term renal adverse outcomes and helping people address short-term AKI problems within the like for instance a septic AKI patient.
So last, if we don't get any more questions from the audience, anything you would wish from Baxter?
And this is also a question I got beforehand, and it had me thinking, and I think it's wise for a big corporation like Baxter to be active in the space of research. And there is, Baxter has IIR grants, and I've been a recipient, full disclosure, of those grants at some point. And I think they're extremely beneficial. And I wish more companies had the insight to do the same, because the healthcare industry and critical care is driven by these like research innovations. So again, if I were in the helms of like Baxter Central, I would actually say that this is part of the R&D. It's not specific R&D, because you won't know what, you could do internal R&D and like, yes, we'll look at this new fluid, or we'll tweak the pumps here, and we'll devise a better warmer. But the IIR grants, independent instigated research grants, actually is a pretty cheap way, I think smart way, to sow a lot of flowers, and some of them will bloom, and they will develop to be really important additions to the market, and they can have true market value really quickly. So to look, and actually, if you look at big and really successful companies, their R&D part is usually quite big. And So my advice to Baxter, and it goes for all other companies as well, is like, even in tough times, if you stay true to your target and focus on R&D with like independent grants and internal research, of course, development, you will become more successful. That it's always worth putting money into innovation. So that's my thought with regard to that.
No, thanks a lot, Max. It's always a pleasure to meet you and have this discussion. So
My pleasure.
Appreciate that you took the time also from the intensive care unit
Absolutely.
and the research work and coming here and
Of course.
talk to us. So really, thanks a lot.
Thank you.
Good. So now we will
Thank
take just going to move to another room. So we're going to take a 15, 20 seconds. Then we're going to start again with the next session. So
Thanks.
Thank you.
Make us more effective in that unit. So with that, Brian, I will hand over to you.
Perfect. Thank you, Magnus. And good afternoon and greetings from the global team here in Deerfield. I appreciate the opportunity to join you today and highlight our GBU focus over the coming year, as well as some specific activities in 2022. And hopefully I can really connect the dots in terms of some exciting information we heard from Dr. Bell. I've had the pleasure of working with a number of you, but for those of you I have not met, I'm Brian Tufts and Global Vice President of Marketing for Acute Therapies. I've been with Baxter coming up on 14 years and in a number of different global and US commercial roles, most recently being the US Acute Therapies commercial lead prior to joining the global team. So I do know the portfolio well of the solutions and sets and devices. I know Prismax well and worked with the US team closely to launch Prismax and all the excitement and features and everything that comes with that, but also the quality challenges with Prismax and the supply challenges on solutions. And I know all too well many of the challenges of this business. And I've experienced that firsthand in a very customer-facing way, like many of you have for the last year or two. I'd say I've also experienced the tremendous impact that our portfolio can have on the caregivers, on the patients, on the families, right? And you just heard from Dr. Bell what a dynamic environment the ICU is right now. How difficult it is and nurses opting out or leaving or doing different things. I have seen the impact that our products and therapies can have in that space. And it's really exciting. It's very motivating to me. I hope it's motivating to all of you. I'm sure it is. And that's why you've chosen to do what you do and excel and focus in this area. It's something that I enjoy doing, that I think we all can enjoy doing it. And the last couple of years have put a very fine point on the need for products and therapies in intensive care for patients that are experiencing multi-organ failure, of how much we can really do to live the mission of saving and sustaining lives. So I have the difficult task of following Dr. Bell today, but I am energized that the focus I'm going to walk through today as a team aligns very well to some of the challenges and opportunities that he highlighted. So if we jump to the next slide here, I've highlighted the three key areas that our GBU team is focused on over the next couple of years, right? And those areas include supply and capacity, right? And we heard from Peter Jarvis a little earlier, and that's really meeting the customer needs right now in terms of the COVID crunch. Oh, perfect, thank you. But also setting the business up for success as these therapies grow, right? And you heard from Peter some of the investments that have been made over time, and I thought he articulated that timeline well, that in 2017, 2018, Sandalo was our only facility producing CRT solutions. We brought online Castlebar. We also brought online the Sao Paulo facility in Brazil to make CRT solutions. He mentioned the first co-batches in Cuernavaca, Mexico, and then our investments in China, which will produce solutions in China for China on a go-forward basis. So going from a single plant making solutions for the globe, and in the not too distant future, we're going to have 5 facilities in 4 continents making CRT solutions, really is going to meaningfully change the game. And the investments we're making in Cuernavaca and the total capacity that comes online starting later this year, but then meaningfully next year and beyond, will provide huge relief to Sandalo and Castlebar and set us up for success going forward to meet the needs of this therapy as it grows. And that's just not pandemic times. That's not COVID times. That's true therapy growth that we've seen on a global basis that we're making those investments to meet. So that continues to be a big focus for capacity expansion, especially on the solution side. In addition, I would reiterate Peter's comment on the devices. Obviously, we've been hard hit with the component shortage, and understanding that's not just our medical device industry, right? That's consumer electronics, automotive, other industries have been challenged by this. But there's a team of folks, as Peter highlighted, literally meeting daily to source all the components for PrismaFlex and PrisMax and continue production of those as best we can to continue to meet the unprecedented demand that we've seen in the marketplace. So I'd start with that right off the top of what can you count on from the GBU. Supply continuity and capacity expansion. Know that is a key priority for us on a day-to-day basis to continue to push that forward and set all of you up for success. The second one would be deliver meaningful innovations, right? So I'm really pleased that we've launched PrisMax 2 and Prisma Lung Plus in 2021. I'm very much look forward to launching NephroClear with the initial market introduction here in early 2022. And I want to assure you that the global team is continuing to look at diagnostic opportunities, monitoring opportunities, digital integration with our Baxter pumps, and also continued therapy evolution in this space and in the ICU, whether that's obviously pulmonary care with Prisma Lung Plus, whether that's next generation hepatic care in terms of liver support. So we're working both internally and externally. There's a number of internal product development efforts ongoing, and we're staying close with a number of small companies that are making investments in this space as well to continue to push that innovation pipeline forward. So it's about the products we launched last year and we're launching this year. It's also about that 3 to 5 year roadmap to make sure that we're consistently delivering innovations to the marketplace and coming with new and differentiated and value add therapies and treatment options on a go-forward basis. So that's another huge focus of our global team. And the last one I put on kind of the broad bucket of empowering customers, right? So what do I mean by that? But really making sure that clinicians have data-driven connected systems that can help them personalize care and advance therapy, right? So some of that is TrueView Connect and simply connecting our devices, connecting PrisMax to their electronic health records, and then leveraging TrueView Therapy Management to aid in the continuous improvement of the therapy delivery and optimize care, right? But it's also stitching together that ecosystem, thinking about diagnostics for early patient identification, advanced monitoring to see how patients are doing in terms of continuing therapy or escalating therapy or offering a different therapy, and stitching together that ecosystem of diagnose, intervene, monitor, and then continue that circle to make sure that we're giving every patient an optimal opportunity for recovery. If we do all that right, we lead to the practice transformation here, right? Transforming practice overall, and you see that folded origami crane here, right? And to the marketers on the team, you're going to see this a little bit more. This isn't going to necessarily be a customer facing thing, but you'll see this internally from the Acute Therapies team, this idea of transforming practice and the visual of, thoughtfully, methodically, intentionally transforming the work that we're doing to then transform the practice at the bedside in the ICU. So that's kind of our focus and our vision right now is to transform practice, and in the key areas there of supply continuity, continue to deliver meaningful innovations, and making sure that we're changing the game for the customers as well. So that's the GBU vision for the next few years. But let's move to the following slide, and then we can focus on 2022 specifically. Right. So here's the investments for growth from a global perspective in 2022. And I would say this is the global slide of 7 priorities that we're working on. And this is the same list I recently shared with the Asia Pac team, and I will be sharing with the Americas team going forward. But I would point out to all of you that it's very relevant specifically in Europe. You'll see a number of things on here that are more European specific. This is our global list. But I would say a lot of our time and focus and attention this year is right on you all and your team here in Europe. Right, so off the top, build momentum of Prismax 2 and Prismalong Plus TrueView, right? So a lot of your countries have already launched this and offering it. We're kind of catching up more on a global basis, but continue to support. I thought that was great off the top that Magnus was showing the impact that you've had. And I think I wrote down 72 centers active in Prismalong Plus already. Is just fantastic. So kudos to you, the entire team that has enabled that and educated folks on what that therapy can offer and are treating those patients with the new therapy. We'll continue to work on that as a global team and give you all the data and information we can. And I guess I would pause there quickly to say that we are investing in real world evidence. I mean, that was one thing you just heard from Dr. Bell, of continue to partner with large institutions on investigator-initiated research and have data-driven solutions. I would say Prismalong Plus is one of those areas. We're making that investment right now to have data-driven outcomes. Second one, and you just heard this from Dr. Bell as well on NephroClear. So the initial market introduction IMI there launched in Western Europe. Very excited to bring that diagnostic to market. And I thought his cautionary tale of make sure that your diagnostic has a meaningful difference on care, right? So it's not just bringing a new novel biomarker to market, but make sure that it's practically integrated into commercial practice. Make sure that when a clinician is checking that result, that he or she is going to do something different based on that, right? That there's an insight, a learning, and either a clinical decision or workflow decision or something that's different based on that. So I thought that was a good challenge to us. And that's another area where we're going to be partnering with the early adopters and first users there to generate data and really set that evidence going forward for NephroClear. I look forward to partnering with all of you to do that as we enter into the diagnostic space and really try to prevent the escalation of care that's often required in the ICU. Oxiris repositioning, right? And this is really driven by MDR, right? So changes in regulations are going to change our label. So we're going to have a new label. We're going to have a new product code. I've been really energized in the conversations I've had with the team leading this, that it continues to move in a good direction for Baxter, I would say. Some of the exact language that's used on the label, moving from excessive amounts to elevated amounts, and the specifics behind our Oxiris repositioning, really thinking less about potential 3-in-1 and just in combination with CRT, but almost kind of as a standalone inflammation reducer way to treat inflammatory mediators. Overall, I think is exciting path for Oxiris. Obviously, continue to use in combination with CRT as well. So that one is going to be later this year, and excited what that means globally, but specifically in Western Europe. Digital health roadmap. I think you heard this from Dr. Bell as well, right? Decision support in the ICU. We talked about automated reports to the hospital. Can we get other ways to see how things are working. And this is where we need to continue to connect devices, right? I mean, I know there's a Denmark and Belgium, and congratulations to a few of you that already worked to get live streams and live feeds off the Prismax devices to both the hospital's electronic medical record as well as the Baxter Data Cloud. I think it's a really exciting direction for us. And as we further look to integrate acute therapies and medication delivery and think about pulling in data off the pumps, off a Starling device, and starting to integrate that in a Baxter ecosystem where we can read back to the clinicians everything we're seeing for the patient, that digital health roadmap overall, how it all comes together, and you think about total fluid management, total ins and outs, everything that we'd be able to really kind of change the game. You partner that with diagnostics on the front, monitoring on the back, and therapy interventions in between, becomes a very powerful and differentiated tool that Baxter can provide overall. And that's really where we're looking to go in the future. The last three are a little bit more, I'm going to say, tactical, right? So increased utilization of install base. You heard that from Christian early on. I'm going to be candid. Right now, we're still in the part of the year where we're having, challenges in terms of making devices and sourcing those components. We're having, challenges meeting the unprecedented demand from a solution standpoint. So it may sound a little bit crazy to hear me talk about, well, let's increase the utilization of our install base. In the back half of the year, I think as we expect COVID to wane a little bit on a global basis, as our capacity comes online and we have more and more product, that will be a very, I think, appropriate time to be back in the ICUs and talking to them about how they're managing patients, how they're treating on a go-forward basis. Obviously, CRT has been heavily used the last few years in Western Europe. Magnus highlighted over 1,000 monitors in back-to-back years. That install base has grown rapidly, and we'll want to continue to leverage that and make sure that all the time and effort that folks have put into the training and learning and patient care with CRT, that we're able to see those benefits going forward and make sure we continue to grow this therapy. In terms of ways to do that, we have the omni-channel enablement, right? And that's a lot about engaging clinicians and caregivers on their terms, right? So understanding kind of those virtual interactions and touch points and giving pieces of information and having a link out there if they want to come through and learn more from Baxter, they can. And making sure that we're continue to engage, especially on our new products and services, whether that's Prism Lung Plus or Nephroclear or otherwise, and making sure that they're aware of that and we're engaging with them on their terms. And I would say that leads into the last one here too, the learning platform, right? The Baxter Critical Care Institute and training platforms. Meet them where they are on their journey and their learning needs. And I think you heard that from Dr. Bell too. I mean, he went so far as kind of the education assessment, right? And that maybe some more novice nurses could start advanced training earlier, and understanding where the nurse is in his or her skill set and where they want to grow and what training is needed on that. So that's investment that we're making on the global side in terms of education, training, support, websites. I think you're going to hear more in a few minutes on the virtual reality training that I'm really excited that you all are leading to put us in a good space as well. So just as we stitch all that together, I wanted you to know what our GBU is working on kind of the next 3 to 5 years. Those were the 3 big areas, and then wanted to go through the specific focus areas in 2022. That's these 7. I like Christian's kind of wildly important goal. I would say in summary, from a global team, from a GBU perspective, our wildly important goal is to make sure that all of you are set up for success, right? And that means supply continuity. That means the innovation pipeline. That means continuing our digital transformation and empowering customers with that data and information and continuing that journey. So we've achieved success as a global team, as a GBU team, if all of you are able to drive that business, to have that conversation with customers and ultimately treat more patients with our therapies. So that's what we're focused on right now. So Magnus, I can happy to take any questions that you or the team might have, or I could toss it back to you.
Thanks, Brian. I will shift, and I'm really sorry. Thanks, Brian, for giving you this. I know we missed some question to Dr. Bell, so because there was a little bit delay here in the questions. So what I will promise you, there was one about CO2 removal, there were one about the quality and training. So what I promise you, I'm going to direct them directly to Max Bell, and I'm sure he's going to respond, and I will send them back to all of you and share his answer on that, so we get the answers, because that is critical and very important. I don't know, Brian, if there is any question to you. So there is one. Can we expect any studies that suggest the use of Oxiris in patients with acute sepsis?
Yeah, so there's a number of Oxiris studies going on, and many of you may have heard about the investigator-initiated research that was proposed to look at Oxiris in cardio. That hasn't published yet, but we're very excited to see what that looks like. That's kind of a different use of Oxiris in the OR. From a sepsis standpoint, I would have to go back and talk to Kai and understand where we are with. I think there's like 7 different IIRs on Oxiris right now in various different places of recruitment. These things take time, so I'm not aware. Let me answer the question directly, Magnus. I'm not aware of any landmark study that we're going to drop in the next 6 months on Oxiris and sepsis. I am aware that there continues to be multiple IIRs on Oxiris ongoing with a number of different endpoints and various different secondary endpoints that they're looking at. So I can follow back up with Kai on that one to understand if there's anything more near term, but I'm not aware of anything that's going to be a big change. I think the biggest change for Oxiris this year is changing the label as it relates to MDR.
Good. No, thanks. And because I think we have improved the evidence around Oxiris over the last couple of years through our IRR grants. But I think we need maybe a little bit more to take the next step with Oxiris and also its place in the treatment. I think the team is doing here a phenomenal job, growing 10% every year or more every single year on this. And it's, as Christian alluded to, one of our key wigs going forward, and has been over the last 3 years. So more support there is, of course, an important part for us to take the next step on this. So appreciate if you can come back, Brian. Thanks.
Yep.
Next question. What is the global expectation timeline until when NephroClear can be considered a standard of care?
You
get all the easy questions.
I know. It's good. I'm gonna turn that right back around. I mean, I think that really depends on our launch excellence, on how quickly we get multiple centers using it, and how quickly we're able to do what Dr. Bell articulated, right? And bioMérieux has looked at this, and they've invested in this, and they do have some data on NephroClear and show the specificity of whether patients are expected to make a recovery or whether they would likely need renal replacement therapy, right? So we are launching with the data that bioMérieux has, and I think that's solid data and evidence to support the use of the biomarker. That being said, I'm super sensitive to what Dr. Bell said in terms of we need to make sure that it's thoughtfully integrated into clinical practice and that people are actually changing the therapy or workflow or doing something different based on the result of the test. I don't think we're at a place in medicine where we just need more information. Oh, just run another test to grab some more data, right? We need insights and knowledge to help take care of the patient. So the answer to that question, and I love the forward lean and optimism in the question that NephroClear is going to become a global standard of care. I love that. I think the pace at which we are able to achieve that is going to be highly dependent on how quickly we can show and integrate it into clinical practice. So myself, our team will be working closely with the launch sites and make sure that we can put a very fine point on that value proposition of where they've started using NephroClear and the decisions they're making differently. Oh, here's post-surgical patients. Here's patients we were otherwise worried about, and we're going to put this protocol in place. We're going to test all of them. And if it's above a certain level, then we're going to put them on a watch list or immediately move to some type of therapeutic intervention. I think that piece of it is going to completely determine how quickly we can make it a standard of care.
Thanks, Brian. I think that was the last question. So I really thank. It's an early hour for you, I know that, but thank you for giving the global perspective on this. And of course, there's a great collaboration between the global and the region here to take the next step in the journey of the acute space, so and acute care. So thanks a lot, Brian.
Thank you for the invite. Thanks.
With that, we will take, I think it's going to be slightly more than 15 minutes, maybe 18 minutes break. We're going to be back with the talk the walk sessions at 5 past the hour, so 4:05 Central European time. This is going into the execution mode a little bit. So please take a well-deserved break and see you 5 past the hour. Thank you, everyone.
Wow.
Welcome back after a well-deserved break. So now we're going to focus on the talk the walk session. So this is actually how we're going to execute on our strategy and most important targets for 2022. As Christian said earlier, he presented the six weeks that we have and the value we're going to create. This is about us. The first one is going to be our team, and then we're going to go through technology, connectivity, Prisma Lung, and our diagnostic story before we reveal the virtual reality CRRT training. So 5 really important, exciting things. Again, we have tried to embrace to have as many people as possible in these 15-minute sessions to give all the different perspective on this. So let me first welcome Andy Warburton on and talking about our team culture. Welcome, Andy and the team.
Thank you very much, Magnus, and good afternoon, everybody. For those of you who don't know me, I'm Andy Warburton, and I'm the business unit head for Acute Therapies in the UK and Ireland. And this afternoon, we're going to start with probably the most critical of the Talk the Walk sessions. If we get this part right and we create the best team culture for our team and an environment where our team can fly, execution of strategy becomes very straightforward. So I'm delighted to say that I'm going to be joined by Zach from the UK team, who's one of our newest sales manager. We are also enjoying seeing Andreas from our DAC and German cluster. Good afternoon, Andreas. And also Marcel, our sales manager for the South in Germany as well. So over the next 15 minutes or so, we're going to share with you and compare and contrast some of the approaches that we've taken in the UK, where we are on the journey to become the best place to work in acute therapies, but we're not there yet. We've got a fantastic team in place, but we have some work to do. And then where we're probably further along that journey in Germany when it comes to best place to work with a more tenured team, more experienced team, it remains absolutely critical that we create the best team culture. So if we can have the next slide, please, that'd be great. So we are aiming to make sure that in acute therapies, we have the best possible team culture, one where everyone can be their genuine self, one where every one of us can fly. Next slide, please. If I give you some context for the UK team, we've actually seen a lot of positive change in the last 12 months in acute therapies. We have extended our family broadly. We have had new family entrants coming into our team from a literal family perspective, some amazing photos here of new family entrants, and also with our own acute family. So we've had new team members joining us, 5 new team members to be precise, 5 new promotions, very, very exciting. So this is a lot of change to bring through one team in 12 months. You could say this is a challenge. You could say this is a fantastic opportunity because we've got a new team, new energy, new perspectives, a fresh culture, building on some of the great work that our existing team already had in place. So in order to get the best of our new team members and our new promoted people, we've got to make sure that we create absolute focus. So in 2021, we had a lot of focus on laser-like focus and creating absolute role clarity for our team. If I can have the next slide, please. We wanted to make sure that we had roles and responsibilities clearly defined, so everybody knew what they were doing. We didn't have any duplication of effort, and we made sure that we set the team up for success. So we created a group of champions, including Best Place to Work champions, which obviously this is part of. We have new clinical and commercial field trainers. We have champions for each and every one of our projects, including TrueView Therapy Management, including Prisma Lung Plus, etc. So all of our team know who to go to for what as the subject matter expert to get further guidance, further support. And we also boosted our marketing team with Rachel and Tommy doing a fantastic job, giving our team the best possible resources and support to create success in 2022. Next slide, please. We have set our team up to fly high in 2022 by making sure that we rolled out our roadmap very early in 2021. So in October 21, we rolled out a fantastic commercial plan for 2022 so that we could really signpost the journey that we were going to go on, the mindset shift that all of us need to adopt and embrace as we move into some of our colleagues' territories where we're thinking about selling services, building the value around what we offer our customers every single day around education. So we rolled this out back in October. And then on the 5th of January, we then made sure that we had a really good kickstart for the year. We got our team together on day 2 of 2022 to re-energize, re-engage and refocus in the business so that we were setting ourselves up for absolute flying high in 2022. One of the key priorities, if I can have the next slide, thank you. One of the key priorities, in fact, the top priority for me and for our leadership team, is to continue to build the best possible team culture in the UK and Ireland team. You can see this is our best place to work scorecard. You can see some green on here, but not enough for our liking, not enough for our team's liking. So we have created some great listening channels, coffee chats with multiple team members to hear what's working and also identify what's not working, so that together we can put in the right interventions and make sure we create the best place to work for Acute in UK and Ireland in 2022. So that's kind of a top level, but what I'd like to get into now is a little bit more granularity, starting with Zach, who's one of our newly promoted team members in the South, our new sales manager for the South. Zach, if you could take us down to a more detailed level as to what you've been doing on a day-to-day basis with building the culture with your new team, please, that'd be great.
Great, thank you, Andy. If I could have the next slide, please. Thank you. So as Andy said, my name's Zach Spencer. I'm the Regional Business Manager for the South of the UK in the Acute team. And this slide is just going to take you through some of the specific things that we've been going through in order to improve and develop our team culture. So based on feedback from our Best Place to Work results, interactions with individuals and groups, including our newly formed Best Place to Work team, which liaises closely with HR, we've implemented various processes to continue to develop this team culture, starting with the wildly important goals. So we have weekly WIGS calls on a Monday morning. This gives everybody in the team an opportunity to inform everyone else on what they've been working on the previous week and the specific goals they have for the week coming up. It means that we're able to support each other as the team get together to share ideas on how best to implement the action that they're looking to do for this week. It also means that everybody is up to date on all things Acute. And importantly, something that we've recently started to implement on these WIGS calls is to ensure that everybody is fully focused on their specific WIGS and their targets for that week. Next, we'll look at feedback. So we're dedicated now to create this culture of feedback within the Acute team. This is to make sure that everybody has a voice and everybody feels like they're heard. It's also a great way for us to get a sense check on where everybody is within the team, on business processes, on how they feel they're performing with their IPGs. And it's a great way to continuously evolve and to fine tune our methods. So we want to hear, and we've asked the team to feedback on how our internal meetings are going, improvements that we can make, and then also how external meetings, how the messaging to our customers is going. So what can we really do to adapt and continuously grow and push forward in our accounts? The next one is looking at taking ownership. So at the start of January, we outlined our new plan for our internal meetings, where previously we had account manager and therapy specialist calls that were run by predominantly the ALT. We've now handed this over to members of the team. So each week somebody will be presenting, and that means that the calls are very much specific to the requirements of the team, what's really going on and really going to impact them, so they can take something tangible out of it and go and perform with their customers. It also gives everybody a platform to present within the team, developing those skills as part of the personal development. We've also revamped our business unit calls. So previously, again, this was very much ALT heavy. Now we're looking at individuals in the team, a therapy specialist and account manager, to present each month based on feedback from the team. So again, it's much more relevant for everybody, much more interactive as well. And then finally, on the ownership side of things, we've created our champions within the Acute team. So specific products now have champions, which means that the team know who specifically to go for if they have a question around TrueView, for instance. They can go, it's much easier and quicker to get some feedback from that individual. This will support the team in terms of development when we're launching our new products and with our existing products to really focus everybody on these key areas. Next, we have our ACE check-ins. So we ensure these happen every month for everybody. And the main focus here is on personal development. So we do allow time to discuss issues that they feel they need to discuss around products and around how things are going. But the main point of the ACE check-ins is to really work on the development and pick out 1 or 2 things that we can work on before the next meeting to ensure that we're continuously working on this development side of things. And then finally, we have the protected learning. So every Friday, we dedicate 3 hours of protected learning time. This allows the team to do their own self-learning, attend the account managers and therapy specialist calls, so we're constantly up to date and as a team united in the same message that we're delivering. But it also aids development so that we are able to continuously work on this personal development side of things as well. And we've given the team the authority to push back to customers requesting training on a Friday morning to say that this will actually work on the ability that we have to deliver training to improve patient care within the hospital. So all parts of patient development and personal development. So that's what we've been working on within the UK. I'll now hand over to Andreas to hear about what they've been doing and the results from Germany. Thank you.
Hey, great, Zach. So for me, it looks very, very good planned, and I cross the fingers, and I'm thinking that you will be very successful with your to building up your team culture. And yeah, maybe in a nutshell for Germany. So what is for Germany the team culture means? So the team culture in Acute Germany has developed over many years, and we have learned from each other what is good, and we have also learned which culture is more toxic in order to go together in a direction to be successful, right? So as a major component of our success is the difference between each individual and respect for people and to see and develop them individually. So in my management team alone, we are 7 people with a total of 70 years of experience in the acute business, right? So the South team from Marcel has 33 years of experience with 8 people, and in the North, the North team has 59 years of experience with 7. So we have an average of 7.5 years of experience with 22 team members. And yeah, all the team members you can see here on the picture. And as you can see, I asked every one of my team what 3 words they use to describe our team culture. And you can see the results here in the word cloud. And as you can see, we are a really diverse team, and it often feels to me that we have to try many new things in order to continue maintain this team culture. In times of virtual customer visits and training, I have to continue my education and yeah, as you see the picture show it as the best. I have to keep strengthening the team culture in the Acute team with my personal view at the virtual reality and leadership. So of course, back to the team and to the word cloud, trust. Trust is one of the foundation for a team culture or for a good team culture. And trust in me as a person, and trust and reliability in team leadership. And of course, trust in Baxter also plays an important role. And here we can say that Baxter has contributed to a positive team culture as well. If there's trust, team spirit can also be wonderfully expanded. And I can proudly report today that the Acute team in Germany enjoys more than positive reputation in the function, so to speak. And to take into the extreme, the customers also have mostly positive words for the Acute team. So, and open-minded means translated for me that we encourage employees to have ideas, bring them in and implement them. That so we as a leadership team also can create the framework, but the design has to be an important part of the cooperation from the team. So And this is a great honor for me to be able to present this team with a team culture created by all team members today with fun and respect. And yeah, Marcel, my sales manager from the South, has been in this position for 3 years. And Zach, I know that, so the big question is how Marcel, and he is responsible for the youngest team in terms of experience years. And I would ask Marcel, if you tell us a little bit more about how you have built your team culture over the past 3 years.
Yes, thank you, Andreas. So my name is Marcel Stork, and I'm the sales manager Acute Therapies for the south part of Germany. In January 2006, I joined Acute Therapies as a therapy specialist. And after 2 years, I changed to sales rep. And when I took this position in 2019, I came directly from the Acute team. At this point, I asked myself whether the team would accept me as their new manager. It's a big question. And so I approached it a little bit slowly. And after about 6 months, I had arrived in the new structure together with the team. I would say our team culture is characterized by the fact that we can work hard, go the extra mile, but also laugh and have fun together. Everyone in the team is open to trying new things and all want to learn from each other's success. The team has the opportunity to be creative, and we are always open for new ideas from the team. It's not just about numbers and performance. This is important, but personal well-being is also very important, is a very important point for us. For me, one of the most important points is that we in the leadership team exemplify this culture and that we work together with a team as one team. You know, I think team culture is an ongoing process that you always have to work on. So I would say, Zach, I wish you and your new team a great journey on your way to create a great culture. Thank you.
Fantastic. Fantastic. Thank you so much, Marcel. Thank you, Andreas. Thank you, Zach. We certainly learned a lot from even our brief interactions together, learning from our German colleagues and hopefully vice versa. So what we've tried to do over the last 15 minutes or so is just give each of our colleagues in Acute Therapies a couple of hints and tips that you may want to take back to your own markets, your own countries, to continue to enhance our culture to be the best culture in acute therapy. So if we get this part right, we advance our strategy together and we're unstoppable. So thank you ever so much for everything you guys have shared with us. We've learned a lot. And with that, Magnus, I'll hand it back to you.
Thanks, Andy, and thanks, team. I think you're absolutely right. If you get the team culture right and how you work with the team, that's the base for creating the rest. And so what I ask the team is also reach out. These two teams have learned a lot from just talking to each other. I think that's what this is all about. Learn from each other as well. That's also one of the purpose here with the Talk the Walk. I will directly hand over to Dimitri, Rick, and Anna to guide us through connectivity and how we're going to drive connectivity, Dimitri.
Thanks, Magnus. And first of all, I want to say hi to all the Acute team members in Europe. My name is Dimitri, and as you all know, or most of you know, I'm the BUH Acute Therapies for the Benelux. Together with my two colleagues, Anna Nieberg and Rick Mahne, we will do this session on operational efficiency in the ICU. More precisely, we're going to talk about ThruView. ThruView is Baxter's new software that analyzes data from treatments on the Prismax platform. This data we can use to create a value-based partnership with our customers within CRRT and OS therapies. And as an American presidential advisor once said, in God we trust. All the others, they must bring data. How this works will be explained by Rick Mahne, who is our digital therapy specialist in the Benelux, and Anna Nieberg, who is the therapy specialist for the Nordics. Rick will show us what it takes to set this up, and Anna will show in a nutshell what's in it for the customer and also what we can do with this data. I also want to mention that the Western European team is the first region globally that has connected a Prismax device to the cloud to gather this data. And the initial global trial will now be rolled out in some of our countries. In Spain, for example, we have 2 hospitals who signed the agreement with Baxter to start the trial, Valdebron in Barcelona and Juan 23 in Tarrasa. Today, Valdebron's account is created, but not live yet. But Juan 23 is connected to the cloud and live data is rolling in as we speak. In the Nordics, we have Ring Hospital in Copenhagen, and this hospital is connected to the cloud with several Prismax devices today, and they are producing data which is visible in our TrueView Analytics app. And last but not least, we have Benelux with the first live connected hospital into the cloud in Soigny. 2 other prospects, the University Hospital of Brussels and Sint Antonius Nieuwegein in the Netherlands, who agreed to run this pilot with us. But it is not a 1, 2, 3 project. The timeline between the agreement of the customer and the final connection to the cloud is a 3 to 6 month process, including getting a broad buy-in from all our relevant clinicians and stakeholders. So a project plan is, of course, very important when we are introducing and implementing TrueView Connect management in a hospital. Rick is going to tell you how and what TrueView is about and what it takes to run this project. And afterwards, Anna will tell you in more details what parameters that we follow in the CRRT treatments and what this can mean to the customer and for us. Next slide, please. And Rick, I hand it over to you.
Thank you, Dimitri. I will say something on bringing TrueView alive. It all starts with updating the Prismax monitor to version 3.2 and hopefully in the near future 3.2 or 3.1. It starts by adding a piece of hardware and software, which is called the TrueView Connect module. It really enhances the communication capabilities of the machine. First of all, the Prismax will be able to output its data in the traditional binary format, so no change needed here, but also now also in HL7 format, which is a much more preferable format for hospital communication. And we will be able to put the machine on the Wi-Fi network, which is a really good evolution. Secondly, directly from the machine, we will be able to export an anonymized data set directly to the cloud. So anonymized directly on the machine, this is really a new concept. I think Baxter is one of the few companies who is doing this. And then when the data arrive in the cloud, they will be aggregated for all the connected machines and analyzed per customer there. The analysis itself will be visualized in the TrueView Analytics app, which is on our iPad, and it is visualized around 5 quality indicators. So actually TrueView Therapy Management is a solution with 3 layers. First of all, enhanced communication. Secondly, data export and data analysis in the cloud. And third, a consultancy service on quality improvement in the ICU for CRRT. Next slide, please. Next click, please. So for the implementation, we approach this as if it were a traditional software project. TrueView Therapy Management for the hospital is a really small project. So there is a real danger that you end up at the end of the priority list more than once. Coming up with a decent project plan will assert a view of cooperation of all people involved and a timely delivery in a controlled environment. Next click, please. The initiation phase starts as soon as you have the go-ahead of the clinical sponsor. Contracts will need to be signed. So you will need to present the solution to people in the C-suite. You're going to give work to people with an already full agenda, and it's important that the people who manage these agendas are on board and supporting you. 2 people are really key here in the C-suite, and one is the Chief Information Officer. He will provide the most important resources for the project. And secondly, the Data Protection Officer. That is the one who is going to sign the privacy agreements, and you need the others on board to push the Data Protection Officer to sign the agreements in a reasonable timeline. Next click, please. The planning phase starts as soon as the contracts are signed. You will need to come up with your timeline and clearly communicate the timeline and the deliverables of the project, not only internally in Baxter, but also externally in the hospital. So I would like to emphasize the importance of doing an external kickoff. This means go to the hospital with sales, with a therapy specialist, with technical services, make some practical agreements, agree on the timeline, and invite all the people who are really going to work on the project. Again, from the IT department, you need 2 people here. One is the network technician. He will be able to put the machines on the network of the hospital and open the firewall where needed. And secondly, the one who is responsible for data integration into the electronic patient record. Those people have blocking power, so you really need them on board. And that's really the purpose of an external kickoff. Make sure that everyone understands the deliverables, and the deliverables are a constant data stream in the TrueView Analytics app and regular meetings with the customer on quality improvement. Next click, please. In the execution phase, you really need to expect problems. If you don't encounter any problems, it's probably because you haven't seen them yet. In our case, during the first implementation, we were really thinking that after 2.5 days, we would have a go live. Everything worked when we were there, but as soon as we left the hospital, it stopped working. Of course, the devil is in the details, and it took us several weeks to actually find the issue. There is a lot of really good documentation that can help you with successful TrueView sales and implementations. And if necessary, if you have an issue or a problem you can't solve, there is a lot of internal support waiting for your call. And your question is surely interesting enough for the rest of us. So reach out for help. Next click, please. Once you have enough data, once connection is established and you have enough data, that's at least 2 months of data, preferably 3, some trends will start to show up in the TrueView Analytics app. Then you can ask the questions, what are the trends showing us? Is there a low-hanging fruit somewhere for quality improvement? And where can we congratulate the customer on a job well done? That's also important. It's really important not to leave the therapy specialist all alone with the data because it can be quite complex. My best advice is to tap into the collective knowledge of the whole team. Some people will have a rather technical view on the matter, and some people will be keen with the group dynamics and will be more into change management. So review the data in group together with the therapy specialist. After that, my advice is to do pre-discussion with the CRRT lead and only then go to the customer and confront the data with the customer. And with that, I would like to hand it over to Anna.
Thank you very much, Rick. Yes, we are running the first global TrueView therapy management in the general ICU at Rikshospitalet in Copenhagen at present. We had some challenges with long data agreement processes, so we already early on started upgrading the monitors with TrueView Connect and used the possibility to manually upload the data from some machines to start with to get things moving along. But now, since the end of December, start of January, we have a total of 10 machines connected to the cloud and data going into our TrueView Analytics app continuously and can be followed daily. The purpose with the TrueView therapy management is to uncover challenges and treatment insights, identify unique performance goals, and to co-create quality improvement program for the CRT treatments. Real data and no guessing. Now we have 5 to 6 months of data, and after 4 months of data collection, we could analyze and determine quality improvement areas to share with the customer, and together develop a meaningful action plan, which will be followed up with review meetings to see if the determined KPIs or key performance indicators are met. We can follow more than 30 different parameters for CRT. Next slide, please. As one example on this slide, with a screenshot from the TrueView Analytics app with real data from Rikshospitalet, we are looking at average filter life. In the beginning of the curve, you can see a higher variance, which is due to only data from a few machines. But then the curve evens out when we have data from all the 10 machines. The data averages are getting more and more reliable. The target of filter life is 30 hours based on studies and literature. And you can see that they are above that target in both 3 months and 30 days, which is really good. There is, of course, also a possibility to look at filter life related to different types of anticoagulants. We can go to the next slide, please. On this slide here, you can see one of the key areas of improvement we are working on at the moment with the hospital. We saw that the filter change time was significantly higher in the day shift, between 2 to 3 hours, and in some cases, more than 3 hours. When we did our root cause analysis, we found that they were ending treatment when delivering patients to examinations and CRTs and CT scans, which is mostly performed during the day shift. That means that they had to end the CRT treatment completely and start up as new patient all over again when the patient returned to the ICU. We challenged the super users why they didn't use the recirculation possibility on the machines. By having to start up a new treatment again, it will mean an increased workload for the nurses, patients getting an unintentional break in the treatment, and also increased costs for the department. By training the nurses to use the recirculation mode on the machine, all of these consequences can be addressed. Next week, we are finalizing the action plan on this together with the super users, which we will follow and evaluate on a monthly basis in the coming months. So, TrueView Therapy Management gives us the possibility to identify quality improvement areas to help the customers improve their CRT treatments in partnership with Baxter. This might also allow us to challenge them to try new treatments, for example, Osiris, Prismalung Plus, now where we can actually follow the data and collaborate on improvements on the CRT treatments. Thank you.
Thank you, Anna and Rick. And I hope we have been able to give you all a flavor of what the new technology can bring us in the future. We strive to have a better, an open and a valuable discussion with our customer based on their data, real data, to show them how we can improve a better patient outcome and how we can make our collaboration stronger and closer. I want to thank you all for listening, and if you have questions, feel free to reach out to us. Magnus, I hand it back over to you.
Thank you very much, Dimitri, Anna, and Rick. Really, I think this is so exciting to talk about the TrueView management and the shift. And we heard Dr. Bell earlier as well. If there is something we can help them with, it is what we're going to talk a little bit later. New innovation, training, but specifically feedback, hands-on feedback or direction at instance where this is going to help us. So I'm really excited. We have now 3 centers ongoing, another signed up. I think it's now time to also spread this further into Europe and see what we can do with this tool as well. So really appreciate giving us the hands-on thinking. This is a journey to do. It is not something you do from one day to another. So really appreciate this. We can, as I said, we can take all the questions in the end. So I ask Dimitri and Andy Warburton to stay on here as we for the Q&A session. We're now going to go into Prismalung. We talked a little bit about it before, but I'm going to hand over to Andrea, Danny, Roberta, and Laurent to talk us through a little bit next steps in Prismalung and how we're going to get to the new target.
Thank you, Magnus, and good afternoon to everyone. For one who don't know me, I'm Andrea Ciandrini, Director of Italy, Greece for Acute, and we can coordinate the session on Prismalung Plus together with Danny, Roberta, and Laurent. Please, next slide. In 21, we have launched as Europe for the first therapy, the ecotherapy and the Prismalung Plus, by working mainly on the early believers. And our target for 22 is really to grow the market. So because we have to increase the number of accounts, the number of customers that will be use this kind of therapy. In fact, every cluster, every country has an important target for the 22. overall, as Western Europe, we have to move from $1 million to $3 million by selling more than 1,300 units. The good thing is that 90% of the country cluster has a proper experience on echo, on the therapy. And the idea of this session is to leverage on the excellence we have developed during 21 to support everyone to achieve the result of 22. For this, I have asked Danny Roberts to work on the educational part, Roberta Montenegro, the therapy specialist from Italy, to discuss about the educational properties of the Echo 2, and Lorraine to talk about the business strategy that were used in France. So without losing any time, I hand over to Danny for the medical part. Please, next.
Thank you, Andrea. In this snapshot from across Western Europe, we see that we have treated over 100 patients with 200 therapies with Prismalung Plus. But what we are seeing here is that echo therapies, as a standard in both the literature and our practice, require 2 therapies per patient. This is primarily because each treatment requires 5 days of echo, extracorporeal carbon dioxide removal. So when we think Prismalung Plus, think patient treatment and think 2 kits per patient. This will allow logistics and confidence in the provision of that therapy. Next slide, please. COVID-19 impacts the lungs in a similar fashion to ARDS, acute respiratory distress syndrome. And ARDS is a life-threatening lung injury that allows fluid to leak into the lungs that causes breathing and mechanical ventilation to be difficult because the oxygen cannot get into the body. Across 50 countries and hundreds of ICUs, the LungSafe study ascertained that ARDS occurred in over 10% of ICU admissions. But more importantly, it was under-recognized and under-treated. The so what, or the reality, is that in mechanically ventilated groups, this syndrome occurs in 1/4 of patients and is associated with a high mortality because a significant amount of these patients do progress to worsening states of ARDS. Common risk factors for this condition include pneumonia, sepsis, and aspiration. But it's not just ARDS. Chronic obstructive pulmonary disease affects millions of people worldwide and is increasing in cases and is characterized by this persistent respiratory symptoms due to airflow and lung abnormalities. But patients with COPD are susceptible to acute worsening of their symptoms with additional therapy requirements, known as acute exacerbation of COPD. In the UK alone, 140,000 patients are hospitalized each year, and that in ICU admission is required in more than 25% of patients at some time during the course of their disease. Across Western Europe, Prismalung Plus has been used to treat difficult to manage asthmatic patients, weaning from ECMO, prevention of intubation, low tidal ventilation, facilitating extubation, and even bridges to lung transplantation. With echo therapies available in the simple and user-friendly platform we have with Prismax 2, we can change the clinical pathway of care that our patients receive. Next slide, please. When we look across the patients we have treated, 70% of echo therapies were provided with CRRT, a tandem therapy, and half of those treatments were done with Oxiris, which we can see on this screen. But my question is, why? Blood purification with Oxiris operates by not only modifying the intensity of pro and anti-inflammatory responses that improve the hemodynamic response of the patient, but also capture the driving bacteria into the membrane. And when we apply blood purification with Oxiris, consistent data shows cardiovascular stability of the patient by reducing the need for both inotropes and vasopressors, as Villa demonstrated in his 2020 registry paper. On the right of the screen here, we have QR codes, and this will take you directly to Professor Alan KOM's ECHO webinar, which discusses this. But look at that liver time. To provide blood purification alongside echo therapy not only limits the patient's inappropriate response to sepsis through this cytokine modulation, but with carbon dioxide removal from the blood, we can provide avenues to achieving lung protective ventilation that allow our patients to take one step closer to home. Next slide, please. Literature on echo not only allows informed understanding on the technical abilities, but it inspires our clinical teams to develop protocols, strategies, and confront the physiological barriers that our patients' diseases present each day. On the left, we have in vitro performance paper by Hospat that explains how effective Prismalung Plus is, supported with education from the medical journal clubs. Left of the screen again, we have Alain Combs' ECHO consensus paper that provides strategies on how to build protocols from the clinical experts and leaders in the field of ECMO and ECHO. At the top left, we have the Consalis paper that explains how effective ECHO in combination with CRRT is with a 22-patient retrospective study. On the top right, we have the internal troubleshooting document developed to aid our education with clinical teams who care for our patients. In the middle of this screen, we have the ECHO approach, which was built in collaboration with senior key opinion leaders, medical, OST, and it provides you a platform of discussion for therapy application. And on the right, we have VCOS webinars that have been available since 2019 across Western Europe that raise and challenge contentious issues in the ICU by providing clarity and consideration. We have over 20 webinars that can be shared with your customers. The QR code on the right will take you to the first French patient case study where treatment with the Prismalung Plus occurred. Roberta.
Thank you. So in my testimony, I'm not bringing you numbers, even though I have to say it's a great pleasure to look at the numbers that Danny showed us before. And being part of the Acute Italian team, it's really, I'm really proud for what we've been able to achieve last year. But I really want to point out that for us, those are not just numbers or filters, but they represent patients. And those numbers hide, in the first place, the great faith that clinicians had in Baxter as a provider of acute therapies in the acute business. In fact, in our background, there was a really strong experience with Prismaflex and the former Accor membrane Prismalung. And that kind of experience is what led us to collaborate with those clinicians who had, even when COVID just started, were asking us for our new Accor membrane, even if it wasn't still available. And I really think that collaboration is the key word for what we've been able to achieve in 2021. Collaboration, not just internally, but especially with customers. And this success, I really believe, is obtained when the customers and the clinicians see us as partners in their daily activities, saving lives. And this is even more important as we experienced it last year when we have to give our support and education mostly remotely. And in fact, the majority of ECHO treatment were started from our remote support mostly. And actually what you can see in these slides are the actual pictures that were taken by the clinicians and the technicians during the really first treatment in Italy that we followed mostly, actually completely remotely. And I really love the fact that you can really see their faces reflection in the Prismax screen. And in that kind of experience, we, as I said before, we supported them only remotely, but we kept a constant communication and contact with the technicians and the clinicians to follow up every clinical and technical update on the treatment. And I really believe that in this context, Prismax made the difference, and with its simplicity was a really game changer factor to achieve the success of the first treatments with Prismalung. Actually, the nurses and the clinicians, even if they were supported only with a few face-to-face training, felt really comfortable enough to start the first treatments basically with remote support. And this is exactly what happened last year. So next slide, please. So we are constantly on the field. We collect experiences and opinions from the users, and I can really witness myself the growing reliability and stability of Prismax. And simplicity and safety, as we well know, are the key features of Prismax, which can allow us and healthcare professionals to deliver the most efficient and accurate treatment to patients. I really believe that 2022 is going to be challenging, maybe because we still must struggle with COVID, but I really believe that we must set a mission and try to grow in the organ support therapy landscape. And I really believe that the main challenge for Prismalung is to build culture about core therapies in those clinicians who don't know or don't believe in the therapy. And we really need to collect the experiences, the best experiences out there, and talk to clinicians and try to build a really strong base to help them to always make decisions, always driven by evidence-based decisions. And in this landscape, Prismax and this reliability and stability can really help us to deliver the most efficient treatment to acute patients. So with this, I will give the word to Laurent. Thank you.
Thank you. Thank you so much. It's a great pleasure to share with you the key success factors in France during 2021. First, all that follows wasn't possible without trust, honesty, partnership, and relationship built by the French team over the last 3, 5, 10 years. It's very important to know that. In terms of targets, of course, we were very focused on early adopters, Prismalung into 2088, sorry. And in terms of sales, we defined our price position based on characteristic and with 2 papers, the in vitro study, OSPA study with and Alain Combe, a position paper. And we had our, of course, the easy setup with the Prismax, and with all those supports, we use a lot the Challenger and Spins process. But it was not possible to do that without a great teamwork. And on the first line, we had, the therapy specialists to be sure that the nurse teams were very confident with Prismax, of course. And after each treatment, after first treatment in our first centers, we collected data from Prismax. Jacques-Alain analyzed them, and after that we organized meeting with physician, Jocelyn, and to collect information about the goal of the treatment, results, and conclusion. And it was a way for us to learn more and more, and again to adjust our messages for the next centers. And what about 2022? Next slide, please. But first of all, we will use again and again our key opinion leader and the most important ones, and to organize a peer-to-peer education to reinforce the rationale. It's very important, and first results. And our next target will be to introduce the therapy in the main center in each area to do the first treatment, and of course to expand the therapy in peripheral centers, which there is not ECMO therapy, and to defend our price now in 2022. We will have a value proposition based on results from treatment 2021, and of course Prismalung could be a door opener in competing centers, And we will try to transform, post-marketing clinical feasibility center into sales opportunity. And but it will be not possible without a great teamwork, as we have already done in 2021. So thanks a lot to the French team, and thanks a lot to Baxter for the tool we will develop for us to reach the goals. Thank you very much.
Thank you, Laurent, and thank you, Robert, for the parts. So I hope that this session will support you in order to get some information. Also, after the session, we will also distribute the slide, the information if you want to read, also get into the what we have shown. And for this, I hand over to Magnus, and we'll take the question after the full workable section. Thank you.
No, thanks, Andrea, Roberta, Danny, and Laurent. I think this is was an important session also for us to give a perspective on how we're going to reach the goal. And as Andrea said, all the presentation from the talk the walk is going to be, we're going to send that out after the meeting. Now we're going to go into the next. We heard before today a little bit about diagnostics, prevention, biomarker. We are, of course, extremely excited to launch our NephroClear. And I hand over to Rosabelle, Julia, and Gilda to lead us through here. So welcome.
Hello, everybody. Thank you very much, Magnus. Good afternoon, everybody. And I would like to play a video before starting our conversation that we are going to have between the three of us. Can you play the video, please? Okay, hello, good afternoon. And first sentence to say is welcome to the new area of prevention and diagnosis at Baxter. I mean, this is the good news that we want to share with all of you, because everything that you have seen in the video is now a reality. And this is what we want to talk about. I'm not alone, as you can see here, but first let me introduce myself. I'm Rosabelle Arce. I'm responsible for acute business in Spain and Portugal. And I'm accompanied here by Julia. She's responsible for acute marketing at Western Europe. And Gilda, as she's responsible for acute medical at Western Europe. Hello, ladies. How are you? But I want to refer to the previous sessions that we have been having had during this KOM meeting. It's really exciting to see how are we expanding our portfolio step by step. We have been talking about Prisma-Lung. Then we will be launching our Baxter Critical Care Institute and for training, education, and selling services. But also we have connectivity that is also up and running, as Dimitri and team was saying. And also we are becoming more sophisticated and more innovative by offering training through virtual reality. So come on, this is amazing, no? But I'm commercial. And with all of that, what I think is that we are having all the enough tools to keep our growing. But sometimes I have to be very honest, where I'm here in my office, which is my home today, is that if I look at our market share that goes between 50% to 80% in different countries, in some countries even more, it's a huge market share. The question to me is, have we reached our ceiling? Is that enough? Can we do anything else to support our growth and to help the doctors? I think that we have the answer, at least a small answer today. That's why I'm here with Julia and Gilda, you both. You have been working in the backstage, not alone, with many people, with NephroClear. And the idea of the company is to go beyond the therapy and enter into the diagnosis and prevention area. That is something that always appears as a strategical pillar in our plans, no, as acute therapy. But why and what for? I mean, I'm curious about knowing if there is still any unmet medical need in AKI. Angela, you are the early doctor among us. Maybe you can help us to understand a bit about this topic.
Thank you, Rosabel. And I think we have been listening also from Max Bell very well a few minutes ago. But also, if I have to put myself in the shoes of doctors we are working with every day, I see difficulties to take the right decision at the right time for the right patient. In fact, the first unmet need I see today is really to have one clear position from the scientific community on renal replacement therapy. We all know that guidelines, KDIGO guidelines, around 10 years ago, back in 2012, they were very helpful to identify the AKI staging, that it means acute kidney injury severity. But if I'm alone in the hospital and I have to decide if I have to start the treatment or I have to stop the treatment, what can help me, really? It's my medical decision, my knowledge, my education. So renal replacement timing, when to start, when to stop, is still an unmet need. Another one, as I said before, and again, Max Bell mentioned, how we can identify the right patient to treat. We can say this patient is in AKI, KDIGO stage 2 and 3, but it's the one at risk of persistent AKI. And persistent AKI, we all know now, it means really that the patient will stay with an AKI that will persist for more than 48 hours. And why is that important? Because, of course, this is an important information, I believe, for clinicians to move on and decide and be a guide on which is the best clinical strategies for this patient. And this was stated by the Acute working group back in 2017 and reinforced in a publication, a recent one, from the same working group in a consensus paper in 2020, when they say that the role of biomarkers in AKI clinical practice is really key. Actually, they really strong recommend using validated biomarker to identify patient population at risk, for whom maybe preventive intervention maybe really show a game changer and improve their outcomes.
Well, it seems that there is still a lot of things to be done. No? However, you've mentioned biomarkers to me in a very general way, meaning that, and also this morning, or this previous sessions, Professor Maxwell also mentioned that there are several biomarkers, and also there is a quite complex topic, no? Is there any specific biomarker to meet this specific medical need that you have mentioned?
I think, Rosabel, the good news is, as we all figured out, it's that there is. And of course, we need to understand that there are several biomarkers already in the market, but most of them are influenced by the concurrent presence of various other acute or chronic conditions. What we have with NephroClear is that we are in a very good position because the NephroClear diagnostic test uses a novel biomarker called CCL14. You will hear many times CCL14, this abbreviation, and it's actually on the slide on the bottom part what it actually means, but I will keep saying the abbreviated way. So the CCL40 is the only biomarker that can accurately and reliably predict the risk of developing persistent severe AKI, as Gilda mentioned before, the term of what is persistent severe AKI. And it is the only one specific for kidney damage and for persistent severe AKI. Unlike other product launches that we have experienced for the past many years now, with NephroClear, we do have 2 clinical studies with scientific evidence, the Ruby trial and the Sapphire trial. These found that the elevated CCL14 levels to be specific to persistent severe AKI. And this is what makes this novel biomarker the most predictive compared with all other kidney injury biomarkers. So this is a very brief introduction on the scientific standpoint. And I think I would like to present what actually is NephroClear CCL14 test, because for some of you might not haven't seen it. So in this slide, you can see that it is a very simple benchtop device. The meter is called the Acute meter, and it's placed in the lab. Urine sample is collected in the ICU and transferred to the lab. The urine sample then is centrifuged, rests for a specific time, and the supernatant is loaded into the test cartridge, as you see in the slide. What it does is that the Acute meter uses an optical system to measure the fluorescent signal generated by the sample, and that gives us a numerical result that indicates the risk of the patient developing persistent severe AKI.
So if yes, Julia, thank you. If I look, I'm wearing the shoes of commercial. So what I see here is that if I look at the slide, no, what I see here is that it is a benchtop device, relatively small. It's not very big. It's very simple to use. What you said is that in the ICU they collect the urine sample, then transfer it into the lab. What I see from my perspective is that this is a new process for all of us, and I'm wondering, how are we going to make it happen?
Well, I will answer the question, but before I really want to, before going into the details of what is coming in the next months, I would like to mention once again, as it was mentioned before by Brian Tufts, that we are the first region in the world that we have this great opportunity to launch a new product. And this is not just a new product, as we can all understand. This is an opportunity that we have to enter into the new space of diagnostics. So for me, this is a great opportunity, and I wanted to share my thoughts on this before going into the next slide, where I can give you some more information in the next couple of slides about what's coming. So if we can have the next slide, please. Thank you. So you can see here that there are many different countries, many different names. So this has been a team effort for many, many months now. And this team has used the agile way of working, and all these people, which you can see their names on the screen, have with different roles, different responsibilities, are part of the preparation for the launch. We have marketing, sales, medical, and market access. For this year, for 2022, what we will have is a limited launch, or an IMI. We usually use the abbreviation. What it means is initial market introduction. And the reason that we have this limited launch is because we need to establish certain key points, endpoints, before having a full commercial launch. And if we can go to the next slide. Great, thanks. You can see that within this IMI, it consists of 8 countries, 15 hospitals in total, 50 patients per hospital, and the duration of this IMI will be 1 year. Once the 1 year is done, so April 2023, we are planning for a full commercial launch around the second quarter of 2023. With the IMI, what we want to establish are certain key points. First and foremost is the medical endpoints or from a medical perspective, what we want to see is we need to understand how this biomarker will be used in the clinical practice and how can this be included in the patient pathway. It was mentioned before quite a few times from Dr. Professor Bell and Brian Tufts, how we can practically integrate NephroClear actually in the clinical practice. This is our big question moving forward, and we want answered with the IMI. From a marketing and commercial perspective, we need to upskill ourselves in the new diagnostic space. We don't have the experience so far. And from a market access perspective, we need to identify and develop economic endpoints that can support the use of diagnostic in the quality of care. So I hope I've given you a nice overview, brief of what the IMI is about and what to expect in the next few months to the next year.
Thank you, Julia. And I'm very enthusiastic about this new journey. And I'm here just representing my entire medical team. We are all excited to start this journey because with the introduction of biomarker in the persistent AKI space, we will ensure really the holistic approach to the patient management. We will advance the science overall and also expand Baxter's scientific leadership. And of course, we will see how we will implement this integrated patient care model. So thank you. And Rosabelle, looking at you from commercial country perspective, do you think that there is any risk somehow to reducing number of treatment impacting your sales?
Gila, we have talked many times about that. And I remember the first time that someone in the company talked to me about NephroClear. My first reaction from commercial perspective was, wow, everything that came into my mind was negative. The first topic was we are going to impact negatively the sales. Second one was, wow, how are we going to tell our doctors that they are not doing the job properly? So that's amazing. I mean, we've been working in this area for so many years. The market is what we want. I mean, the market is, we have been able to shape the market. And now we are going to tell them that they are not doing the things properly because of this monitor. So, but now I have to be very honest. I have the full picture and I try, please, if you go to the next slide, what I really think about that is that listening what you have said and knowing that there is a real unmet medical need. So the scientific community today, they are asking for more clarity on RRT timing, but also on how to identify patients. And also Professor Maxwell said during this morning, no? And apparently, and based on the scientific information, biomarkers is the way. So if I talk about biomarkers, I want to talk about NephroClear because NephroClear is the only one able to predict the risk of developing persistent AKI. The most important thing is that the only one that can do that in an accurate and reliable way. So to me, this is the natural extension of our portfolio. I mean, and also it's completely aligned with the unmet medical need. So we have a unique portfolio. And also, which is quite important, we have clinical trials to prove and to help us to demonstrate the value of NephroClear. If I wear the shoes of the doctors, that sometimes we have to do that, from the medical point of view, what I see here is that we are helping them to make better decisions. Because those doctors that are not treating, they will see that they will. Those that are already treating, now treating, they will ensure that they are doing the right things. And from my perspective, I'm wearing my shoes, my own shoes. What I think is that having NephroClear, I mean, we are enlarging our portfolio, we are having more opportunities to grow, and we are positioning Baxter and ourselves as in front of our competitors. This is at best a unique opportunity to differentiate, because we will be the first one and going beyond the treatment and towards the management of AKI. And from the country perspective, from commercial, but now let's talk about the country perspective. I've been working in the pharmaceutical industry for many times, and I have to say that to me, to launch a product like that, with an IMI approach, meaning initial market introduction, to me is a very healthy way to launch with a very clear plan, because what the company is trying to do is to gather the voice of the countries, but not only the doctors and clinicians' voice, but also our voice, because we are the ones responsible of selling the product once it is available. So with all this information, what we are going as a company, we are going to learn. We will be able to adapt based on the voice of the countries and the market. We will be able to adjust and to be ready to do the best launch ever. So with that, if I put everything together, please, if you go to the next slide, believe me that my first image that came to my mind was that there is no ceiling and we have everything to succeed, and the sky is the only limit we have, the Acute team. So thank you very much, Julia and Gilda and Magnus. I hand over to you. Thank you.
Thanks a lot, Rosabelle, Gilda, and Julia. I think we are really excited about this going into the prevention space and the biomarker part. We're going to learn a lot during the journey here in the IMI, but it's really, really exciting for us. Equally exciting, I'm going to hand over to Dara, Stephen, and Sasha, and let's get the show. I have my goggles here, so if you, I will put them on. So, okay, leave it to you.
Thank you, Magnus. So it's my pleasure today to talk to you all about the PrisMax VR project, give you all an update on progress to date, give you guys some insight into what the application looks and feels like ahead of the official launch. You'll all finally get your hands on it. So we're going to start off with a little promo video that's been prepared for us. It'll give you guys an insight into what the environment looks like. And then I'll let that play, and then I'll come back to you guys. So if we could play video 1, please. Thank you. So as you can see, the application is really taking shape now. The environment is complete, and the PrisMax has been rendered. There's some final touches being put in place with regards to the atmospherics, the sound, the lighting, to introduce as much realism as possible and to make the training environment as immersive as possible. Could I have the next slide, please? And on again. Yeah, perfect. So this is the roadmap. We're targeting May for completion of all of the modules. To date, the CVVHDF with citrate has been complete, and there's a lot of work still going in relation to the other modules, the other training modules. There's different types of training modules that are being developed. There's the core training modules, of which there are 10, and you can see them on the screen. Then we've got additional assessment modules. So these are the ones that the healthcare practitioners will be assessed against and can, we'll be maintaining their training record for them. And then finally, we've the open practice modules, which will allow the clinicians, healthcare practitioners, just operate within the environment and practice, the various different activities and therapies that exist on the Prismax. And that's a unique value add to this product, because for them to try and get access to practice these things on a real world Prismax is very difficult, as you all know. So next slide, please. We've talked about this a little bit in the past, but as you know, we've specifically chosen virtual reality because of the nature of virtual reality and the fact that it's completely immersive. So the individual who's going through the training is surrounded by a virtual environment with no distractions. They're there focused exclusively on the training. Sometimes when you use some of the other reality technologies like augmented reality, it overlays the virtual world on the real world, and that's not what we wanted for this project. It's perfectly useful for other projects, but we've specifically chosen this, and a lot of our research has led us to believe that this is the unique technology that will allow us to deliver that. So what we're going to do next is Stephen's going to talk us through, as our health therapy specialist, he's going to talk you through using one of the modules and what it looks like with wearing the headset. So if we could play video 2, please.
Thanks, Tara. So for those of you who don't know me, I am Stephen. I am one of the therapy specialists in the UKI, and I cover North London. So what we wanted to do with this video was really give you an insight and give you a few select snippets of what it's like using VR on or what it's like using the machine on the VR platform. So in case you've missed me, I'm the one down in the bottom right there in the bright pink. And I'm obviously using the VR platform in real time. For those of you who don't know or are unfamiliar with virtual reality, it incorporates a headset and 2 handheld remote controls, so 1 in each hand. And what we've tried to do with this platform is incorporate, yes, the written instructions on the machine, but also some blue box instructions as well that appear on both sides of the Prismax machine as well. So they're sort of like add-ons or sort of helpful tips just to help the user kind of recognize where different parts of the machine need to plug into. There will be the option of the voiceover as well during the module or during the training interaction, so that there will be an actual voice reading out those blue box instructions as well, just as an add-on, again, to help the user kind of use the platform if they're unfamiliar with it. You'll see as well that there is a trolley to the right-hand side where all of the different pieces of equipment appear to be for use on the machine, on the platform as well. And what we found during the formulation process of the platform was the environment, how important the environment is in the ICU, and how it contributes to the training experience as well. And I think most of us would kind of agree that a lot of the time the environment can either help or hinder in terms of training. So we're really trying to incorporate the ICU environment as well as the sounds and the haptics as well.
Dara, you muted?
I was muted. Apologies.
Thank you.
Thank you. So we have developed far more than just the app for virtual reality. There's also the web-based training, which will allow users to partake in the same quality Prismax training, but do so on a standard workstation, because it won't always be appropriate to do the training on a virtual reality headset. Sometimes they'll just need to do it. The environment won't allow that. So we've provided the same quality training on a browser-based simulation. So they'll still be able to have all those same quality interactions. All of the healthcare practitioners' training records are managed and maintained on their behalf, and we'll continue to do that as part of the service. And all of the platform is supported by Baxter. So it's an end-to-end service that we provide for the whole platform, and there are dedicated teams that will distribute the headsets, maintain and manage the user records on behalf of our customers, and then provide both post-sales and pre-sales support directly to our sales teams, healthcare practitioners, and also to the clients themselves. So on screen, we've listed some of the perceived benefits that we expect to be able to deliver to our customers by providing them with this platform. And I'm looking forward to any questions you may have at the end of the presentation in relation to the launch or any aspects of the platform. So we're going to go into some questions and answers now, because both Stephen and Sasha have had an opportunity to look at this technology. They've been involved with the project since the beginning, and they've helped shape the project in terms of their contributions and their expertise. So it's a unique opportunity to learn from their experience. So thank you, Stephen and Sasha, for your time today. I'll go straight into the first question. So what have been the core idea or principles you and the team have had in mind as you've helped to shape this exciting new training platform?
I think for us, what has been sort of the core idea between myself and Sasha and therapy specialist in Ireland, Celestine Smith, is realism and detail. What you need with VR is for it to be realistic and as much detail as possible so that you can emulate actually being in front of a machine. And what you don't want for it to be is in any way gimmicky. So the more detail and the more realism you can actually bring to the platform, the more credibility it's going to have, and the more you can use it as an actual resource for education and as a tool for helping clinicians to actually become familiar with Prismax.
Fantastic. Thanks, Stephen. Sasha?
Yeah, I'm on this point. I fully agree with Stephen. And if I can talk from my experience, if I take the first time on the classes and can use the VR tool, and I was so, how to say, it's enthusiastic and happy if I see we have a Prismax twin completely working. Every button I can use at the original Prismax, and was an absolute fantastic feeling in virtual reality to say, okay, I can use a complete Prismax, but I don't have any Prismax at home. So I only need the glasses, and it was for me what's absolutely fantastic.
Fantastic. And that's great to get your perspective on that. What do you think are the main advantages of virtual training over more conventional training approaches? Stephen?
I would start by saying it's availability and ease of access once it is actually on the unit. I would say, the way in which users can just pop on a headset if they have a spare hour and look through how to set up an actual Prismax machine, rather than trying to get one that may not even be free. All machines may be in use. The availability of it, it's quite easy to use, which is something that really struck me, having had no real VR experience in the past as well. You really become quite familiar with the platform quite quickly, which so it doesn't distract from the actual training content and what we're actually trying to teach clinicians and nurses as well.
Fantastic. What were your thoughts, Sasha?
I think on this point is important part was Dr. Bell said we have. I remember from my time at the therapy specialist at Baxter, I remember that new nurses are coming on the ICU and get many input about machines and then get the training of the Prismax or the Prisma Flex. And I remember after 20 minutes, I think then are absolutely overflowed of information. How work the machine, what is CRT, what is citrate, then the complete wording of the machine, auto effluent, what is transmembrane pressure, filter pressure, and all the things. And now this is a very good part to, how to say, to make pre-work before we come a face-to-face training with a therapy specialist. The nurse can have a pre-work so they can more concentrate on the details of the machine, of the therapy, and have, how to say, the wording and the basic knowledge of the machine he has learned about the VR classes. And this is, I say, 24/7, 365 days in a year, what the nurse can do with this. So I think this is very important for new nurses on the ICU.
Agreed, absolutely. So, given both of your unique histories, with training, are you concerned that technology of this type replaces the need for therapy specialist training roles like yours?
I think virtual reality is a new tool that we can use. It's a new resource. I don't think that it is ever going to be a replacement for therapy specialists or training overall. I think, Baxter is mainly made up of former clinicians, former nurses like myself. And that's how Baxter has obtained credibility in the industry as well, that you have former clinicians that are going in and doing the face-to-face training. A lot of us, were spoiled in terms of being able to work from home during COVID. Our counterparts in hospitals don't have that luxury. They have to attend work every day. And the fact that those of us that could go in and be face-to-face and do training was really important for them to see as well. And it's how we've built up credibility. So the role will never be redundant. VR is just a new education tool that we can use to help better prioritize and sort of empower customers to be able to take responsibility for their own training as well.
Agreed. Sasha, what are your thoughts?
Yeah, I think same as Steve. And I don't think that is a replacement for therapy specialists or for face-to-face training. I think it's a on top on a station to use trainings in, I say, without any machines or everything. But I think we must know that is only one classes for one person. As a hospital now make, say, a training session with 10 nurses and 2 physicians or 3 physicians. So this is a part we get a face-to-face training. And I think this is a very great tool for ICU, for nurses or physicians to prepare some training for, I say, for the first face-to-face training, or refresh some knowledge about the Prismax, or to find some troubleshooting. If I say, okay, I have this problem, let's look what says the blue box, what says the text, or what the help button, and I can use it on the VR to look if I find a solution of my problems at the machine.
Fantastic. So, what excited me most about being involved with this product is we're developing a new product line, for Baxter to sell. We're delving into brave new territory where we're selling training as a service. So can I ask you both, what do you think needs to change or happen to make VR a commercial success?
I think the most obvious thing that needs to happen is that we need to start, or if we haven't started already, start charging for training sessions that we currently give, and not be so willing to go in and do training for a unit that has 1 or 2 new starters on the unit. It's important that if we're going to be charging for virtual reality, that we already charge for what we're currently offering, which is the face-to-face training element, because that will always remain the top level of training. VR is not there to replace that. But in order for that to be viable, we need to be able to have a conversation about charging for what our current offerings are, or at least have a clear strategy as to how we incorporate that then as well.
Fantastic. Sasha?
I think a very important point to bring the VR on the market, I think, is that customer have the chance to use it, to see it before they buy, because it's not many people to know or to understand what is VR. I think this is a small area of people who know that. At example, we use it in the German sales meeting, and every says, "Wow, it's fantastic! 3 people buy directly a Oculus Quest," and I think it's a challenge, and I think it's not a challenge. Why? I think if we come to, I say, to leader of an ICU station, and he's an older person, I say 50, 60-year-old, this is not a technique for him. Because I think this is more a challenge to show them what is VR, what is the benefit of your nurse, of your station, what everything. If we have younger people, I think this is easier to bring the value on them. They are hot to new technique, to new devices, and they are. I think that is easier to bring the VR than, how to say, older people who is from the technique a little bit behind. I say then it's not so easy, I think. But this is a point, they must use it and they must see what can they do. This is complete interactive. I can do the same at the machine, and I think that is impossible that they know what they buy.
That's a great point you've made, and I would agree. So, final question to you both. What would you say to those that are still hesitant or dubious about virtual reality and the virtual platform as a whole?
I would say I used to be one of them. In that I, come from a nursing background, didn't see how virtual reality could be incorporated into a hospital, let alone an intensive care unit. How do we train on a machine then, if that is the case? I was very dubious about it. And then when Cassette started producing what they've produced, and we saw in the video what they have produced, and just seeing how easy it is to kind of come to grips with, and sort of, obviously I'm familiar with the setup of the machine, but virtual reality, I'd had minimal to no experience with it before. So, it's that kind of thing where VR is already in hospitals. It's used to treat certain conditions. It's used in treatment of ADHD. It's used to mimic ORs. It's also used for PTSD patients as well, to help them sort of overcome their PTSD. And we know that a lot of long-term ICU patients go on to develop PTSD as well. So my own hesitancy I've been able to overcome by actually using the platform, but also the platforms that we're using currently for virtual training, like Teams, like Zoom, I should say, don't necessarily lend themselves to training in a hospital environment. They're not as visual as I think most doctors and nurses would be in terms of learning. And virtual reality is literally a visual tool. So could potentially garner a lot more knowledge from using a visual tool as opposed to potentially a more corporate kind of way of doing virtual training.
Thank you, Stephen. Sasha?
Yeah, I see it completely same than Stephen, and I have a little bit longer experience with VR. I'm using it over 4 years at the moment, and I think with this point we are on the baseline. We have so many potential to the VR sector, from training, from medical part, from machine training, from everything, and I think it's easy to use for everyone. I think it's a little bit training, and I think that VR is a future in training process, is a future in working. At example, at Mercedes-Benz, there are all developments working with VR to construct engineer and instruct models from cars. So I think this is a future, and it's coming more and more of the VR side.
Agreed. Well, thank you both for your time today. I appreciate your contribution, and throughout the project, you've helped steer and shape the direction this is taken, and all the therapy specialists have been involved, from the early stages of this project, and it was their advice, and it was their direction in terms of, what we were doing and how we were doing it, that really has brought us to a point where we have a truly excellent product to launch now in market. So thank you both. And Magnus, can we pull you back out of virtual reality? Are you still in there?
Yeah.
You're back.
No, that would be great. Thanks a lot, Sasha, Stephen, and Dara. And I know there's been a lot of work and intense work over the last, I would say, 8 to 9 months around this, since we really kicked this off and presented this the first time. This is a huge investment we do, but as you all expressed, there's a huge, I'm really looking forward to this. I'm curious to see what we can do. I think our customer are as well. And as you said, we are going to charge for everything we do. We're not going to give, I said in the beginning, we're not going to give education away, even if it's face-to-face or virtual. The same is going to come for this. We're going to charge them an amount per month to have this. On the other hand, they can be trained anytime, anywhere without the monitor. I think that's a huge thing. Looking into the lack of staffing we have and new nurses coming into the units, that you can do that is an enormous thing for us. And if the question was, do we think we can have less therapy specialists? I said, no, I wouldn't think so. I think maybe more, because I think this is about the education training. This is just one feature out of many that's going to come into this space. So I really look forward. Education and training is a key part and a core of our acute therapy business. So thanks a lot for all the time and everything you've done on this. And I'm looking forward. I know we're going to have a session for the Train the Trainer in end of March, somewhere in Europe, where we're going to look at this live. So I really looking forward to be there in person as well. So thanks
Excellent.
a lot.
Thank you, Magnus.
Thank you.
Thank you.
And please stay on for any questions. We are slightly behind on time, but we're going to take a few questions here we have in the chat before we take a break of 10 minutes and then go to the award ceremony. So the first question is about TrueView. And I think, Dimitri, I will give this to you. You were leading that session. What advice would you give to a team about launching TrueView?
Thank you, Magnus, for the question. It's an interesting one. I think the first advice is the first goal is to find a clinician who is interested, because there's always somewhere in the ICU that is interested in this data. Until now, we have had a lot of conversations yet, especially Rick and the team, on TrueView therapy management, and we have never been turned down yet. So first of all, try to find the person that is really interested. And I think try to move fast forward by including TrueView therapy management into a package deal together with a purchase of a monitor or a bigger deal on services. And I think it's also advisable to get a large customer buy-in, as Rick explained in the beginning. Try to find some people who can help you by getting the data, but also who are interested in getting the data and improve the care and also that are the innovators in care. So that would be my advice to do.
And of course, we can't see who addressed the question, but what I would say is, like in each of every of those 5 sessions we've had, reach out to the people in this session, ask the questions. We are a fairly small team. I would reach out, ask those questions, have a team meeting, Zoom meeting, set it up, learn, and share your experience of this. I think that's the fastest way to get forward with each and every of these discussions we have had today. 2 questions about Prisma Lung. Andrea, you were leading that question. I'm not sure if you can answer this one, but is the therapy ECHO reimbursed in your country as in Germany?
Thank you for the question. I talk for the Italian experience, then probably I will try to gather information for the other countries. So for Italy itself, we have not a specific reimbursement. I have to say that the reimbursement is not a roadblock for the expansion of the therapy nowadays. I think that, talking as Dimitri said, if you have a real believer that believes in the concept of supporting the lung by echo. You can also support the expenses related to the therapy. So, but we get the information for other countries to reply for the overall Western Europe. Thank you.
Thank you. Another, how much feedback do you get on the old Prismaline filter and the obstacles for getting efficiency impact on Prismaline Plus?
Okay, obviously this is more the Italian experience. I have to say, in terms of feedback from the old user, we have seen positive feedback because mainly the performance, the physician, they have tried both, they have seen an improvement of performance on removal of CO2. Easiest approach, because remember that the new Prismaline Plus is in the front of the panel of the Prismax. Instead, the old one was on the side. It was more complicated to control during the treatment, and also the ease of use is better in terms of also supporting from the monitor. In terms of the second part was the difficulties. I think that we have seen the standard difficulties of this therapy, so mainly the blood flow and the catheter. That is the standard difficulties of this therapy, and in some starting cases the anticoagulation. But I believe more because the customer now is more used to work on citrate, and moving back to heparin in general is less used to work on heparin anticoagulation than in citrate. That is becoming really the standard.
Thanks, Andrea. There is also a question on, Julia, GAMCAT availability. I don't know if you can answer that straightforward or if you want to come back on that one. That's of course an important one when it comes to supply.
I think I can come back to that and have more. And if the person who has asked this question can be more specific, or is it the product codes, is part of the simplification project? So just to have more details on the question so that I can give a more accurate answer on this.
Thanks. Dara, there is also a couple of questions on the VR, of course, because that hepatic element, so liver, is that a training module on the VR?
Great question. There is haptic capability built in to some extent. So there's two different ways of interacting with the machine. There's either using just your hands, and the headset will pick up the movement of your hands. In that situation, there's no haptic feedback. The other option is to use the controllers. When you do use the controllers, they look like this. There is haptic feedback. So when you reach out and touch something, there's a very barely noticeable vibration to let you feel like you've touched something physical. As the technology develops and goes forward, we expect that we're going to be able to build a lot more haptic feedback into our products. So this is version 1. We've used the full capability of the existing headsets, but we expect next generation headsets coming out of the next couple of years going to offer even more capability. We'll probably get to a stage where you'll have gloves, which will offer, complete touch haptic feedback. So even heat, cold, all those wonderful things. So more to follow on the technology.
Great. And I think if we're talking training modules, there is plenty of them. We don't see the question yet. I think there is a pricing question as well on the VR. And as I said, we're going to charge for it. The price for this is $500 per month. Okay, and it's going to be a 24-month contract. Just to be very straightforward and transparent on this. You can of course charge much more than that, because the availability for training 24/7 without the monitor at any time, with all the different modules and the monitor per se, the value of that is enormous. And then the hospitals, of course, decide how many goggles do they want. Do they 1, 2, 3, 4, whatever. But I think it is a fair market value price to charge 500. Maybe we should have charged even more, but we need to start somewhere. And let's see when we develop also new things. New goggles are going to come, development goes faster. We're going to develop new things when software upgrades. Let's see where we are then. But that's the starting point, and the challenge for all of us to get to that point. But...
Yeah, thanks, Magnus. And I think given the level of investment that's gone into this platform and the fact that it is far more than just a headset, that it is the full training record platform, supported, end to end by Baxter. I think we've come in at a very aggressive price point there. That's very low. It's a lot lower than what I was expecting.
Thanks. Okay. If there is maybe one or two questions we haven't had time to answer, we will do that in written and come back to this team on that. I wanted to give us some time, take a break before we go into the EMEA Elite Award. Let's take 10 minutes break and be here sharp at the hour, and we're going to kick off the award winner for 2021 and see where the trip also goes for next year, this year's winner for next year. Okay, see you in 10 minutes, everyone. Thank you.
Thank you.
So congratulations to all the winners of the 2021 Awards. It is your dedication, your hard work every day to support our mission to save and sustain lives that make the difference. I look forward to celebrating with you in Oman. I look forward to a great time together. Have fun and thank you again.
So welcome to the EMEA Elite Awards ceremony. This is a pleasure for me to present the winners we have from an Acute for the performance in 2021. And as you just saw, this trip is going to go to Oman. Before we go in, I just want to make a few remarks. We have for this year 4 places for account sales, account manager, and therapy specialist, and we have 1 for the sales manager. So we have 5 in total awards we're going to hand out tonight. When we go and look at, we talked about Oman. This is a trip for 2 people. You know that we have moved the trips over the last couple of years due to the pandemic. This trip is now moved somewhere in the fall, October, somewhere in October, most likely. And it's for 2 people. So every winner who's going to win is for 2 people. The rules to be a part of this and to get eligible to this is, of course, the sales as normal, the sales versus target in percentage over target and in dollar. So it's percentage and dollar over sales target, sales over target. It's the sales versus 2020, so the year before, growth in percentage and in US dollar. And it also, the core thing for us, we talk a lot about ethics and compliance and values. These are fundamental basic things we always check. Certification of the certification that we do in December, January every year, and to be boost compliant in that as well. So these are the core values we built this around. So let's then jump into the first winner. The winner of the first person has a sales target 135% or 35% over the sales target with a total value of nearly 2.7 million and growth versus 2020 with 15% or in value 1.3 million. That is a huge achievement. Huge achievement. So our first winner tonight is Roberta Montenegro. So big congratulations, Roberta, to this extremely good achievement and result during 2021. And together I have the business unit head of Italy and Greece, Andrea Sciandrini. Please, Andrea, a few words about the fantastic and phenomenal achievement by Roberta.
Thank you, Magnus. I think the numbers say a lot. So we have seen incredible results for 21. But I think what is important from Roberta, I think that she's really great in her mentality, in that support to the team. Is the first that asking support and receiving support from the team. So I think that she's really deserved this kind of award, because it's really a role model for the mentality that she uses every day in the daily practice. So I think congratulations to Roberta, really deserve award. Thank you.
So big applause from Andrea and myself. Unfortunately, we cannot do this from a stage.
We cannot be
big
closer.
applause from both of us, and very well deserved, Roberta, and have a big pleasure on the trip as well. Let's move on and go to the next winner, with a result of 40% above the target, or nearly $1 million, and with a growth of 37% versus the year before, or 945,000, nearly 1 million as well. The winner is Konstantina Tutsi from Greece. Very well deserved, Konstantina. I think you won the prize also 2 years ago, if I remember right. So I know there's been extremely tough conditions in Greece, but extremely well deserved. And thanks a lot from myself. And again, Andrea, I invite you again on the stage.
I'm really happy to be here again, obviously. I'm really proud that we have a very girl power in my cluster because Roberta Costantini really did a really great job in 21. I have to say that Costantini really helped a lot the Greek team. They also changed this year after March. So we have a new organization, and Costantina is supporting the Greek team that after the summer really was faced by a very hard COVID wave. And Costantina and the rest of the team did a great job. Costantina, obviously, working in Athens, support a lot of customers in very complicated situation, and this result comes from this situation. So thank you, Costantina, and really deserve award.
Thanks a lot, Costantina. Good. So that was 2 winners, Roberta and Constantina. Let's move on to the next one. And the winner result for the next person, it is an overachievement of 48% versus target, with a 1.5 million, or a growth versus 2020 with plus 11%, or nearly 500,000. The winner of this prize is Ashley Flight from UK. So big congratulations, Ashley, from myself, and for the great performance in these numbers. I know there is a lot behind of these numbers as well. And I have invited Andy Warburton up and talk a little bit about that. So hand over to you, Andy.
Yeah, thanks, Magnus. Absolute pleasure. I'm so happy for you, Ash, and I know the entire team will be. This is an incredible achievement and very, very well reserved. The sales figures speak for themselves. The growth speak for themselves if we think how strong we performed in 2020 as well. So, but what this doesn't tell you, the numbers, is the activity that goes behind this. So Ash has done this. She works very, very strongly and very collaboratively with her partner in crime, Marie, who's been off on maternity leave for 6 months. So she's done this single-handed. So she and Marie, prior to Marie going off, have managed to land a 21 machine Prismax order in Wessex and really set up TrueView therapy management and all the future therapy that we can build into that account. So just incredible. She's created also a winning formula for Oxaris with new account orders, but then repeat orders time after time after time. So she epitomizes account management. She is determined, tenacious, absolutely committed to hitting her numbers and helping her colleagues out. So this is a very, very well-deserved award, and I'm absolutely thrilled for you, Ash. Enjoy the trip, and thank you for everything you do for the UK and Ireland.
Big congrats, Ash, from Andy and myself. Thanks for all the great things you do. Let's go into the next award. This is the last award from an account manager or therapy specialist prize. This winner have achieved 27% above the target, or nearly more than just above 900,000. Growth with 23%, or nearly 800,000. And the winner is Florian Klaffner from Austria. Great achievements, Florian, and thanks for these great results and a big congratulations from my side. I've invited Michael to talk a little bit more about your performance as well. So welcome, Michael.
Thank you, Magnus. Thank you. Yeah, I'm extremely pleased and happy to have someone from the chat team among the winners again this year. The area for which Florian is responsible is a very special one in the chat region. Very critical but very loyal customers who have very high standards. And Florian, he always focused on the patient in order to achieve the best possible success for customers through our therapeutic range and knowledge. And what I have to say, thank you to your tireless commitment together with the team, and he managed to convert many accounts to Prismax last year. And this is also a team approach, technical service, training, and so on, medical, marketing, yeah, everybody in the team. And it is now the second time that Florian has received this award. In 2015, he went to Peru. So let me say again, thank you, Florian, for everything you have done to achieve for our patient, for Acute team, and for Baxter over the last year, and you really deserve it. Thank you, Florian.
Oh, thanks, Florian. For great achievement. So let's now move to the Best Sales Manager Award. And the winner here have achieved 31% above the target, or 2.7 million, with a growth of 8% versus the year before, or 800, just above 800,000. And the winner is Maurizio Polacina. So with that, I invite Andrea back on stage again for the third time.
Okay. Thank you, Magnus, and thank you, mainly Maurizio. Maurizio for his incredible 21. He managed a lot of incredible activity during 21. He managed to support the rollout of a huge tender in Lombardy, and also working with the national tender for ICU in Vitalia, and this really helped to achieve this incredible sales result. Also the dedication that Maurizio has in every also little aspect of our job is really important. So he believes really in what we are doing, sustaining life approach, and so he really deserves this kind of award, because he have done a really good job, not only 21 but in the last 20 years in the company. So he really deserves. Congratulations to Maurizio.
No, congratulations, Maurizio, from Andrea and myself, and from the leadership team as well, and to all the other winners as well. So extremely well deserved. So all of you five, we're going to post this on our Jammer post as well for the Acute. But really, I hope you're going to enjoy the trip to Oman together with someone that you choose. So a big thanks to all five of you who were the winner, and big congratulations. Thank you very, very much. Can you please now, Jackie, cue the video for next year's?
And now it's time to celebrate. Every year, the Elite Awards celebrates the top 5% performers from the commercial organization and the top 5 contributors from the support functions. Making it to the top is not easy, yet some of you have managed to do so more than once in the past years. You are the best of the best, and I salute you for your performance and for everything that you do for the company every day. The winners of the Elite Awards are invited every year to a fabulous trip to a fantastic destination. I have had the privilege to host many of these trips, and I can tell you they are fantastic. They're a great moment to spend some time together celebrating. I hope you will be one of the winners next year. For 2022, we have taken another great destination that will remain in our memories and in our hearts for years to come. Let's roll the videos.
Great. So next year's trip goes to Apulia in Italy. So we hope to have many from the new MD Acute team to go to Apulia and get the award for next year. But once again, let's celebrate. And now we're starting to go into our team meetings for the rest of the week. Let's celebrate the winners, of course, of the EMEA Elite, but also celebrate in each and every country the great, great performance you all have done, as we started off today with. And remember, this has not been for free. This is only due to your extremely hard work and team spirit and collaboration that have made this happen. So I just want to once again thank you so much for a great, great achievement in 2021. And I look forward to celebrate an equally successful 22 together as well. So with that, I hope this session has been focusing, and you feel that we've been focusing on the 2021 result. and the feedback on that, also giving you an external perspective from Max Bell, and give you an interesting view on the walk the talk sessions. Reach out to these people. This is how we're going to execute, and these are important execution that we need to done. And then the celebration in the end with the award. So big thanks for staying on 20 minutes longer than it was supposed to be, but I really thank you for an enjoyable session, and thanks to everyone who was also part of presenting it. Really appreciate that. With that, we conclude and end today, and see some of you in the next coming days in your team meetings. Thanks a lot, everyone.